Call this meeting to order. Welcome to meeting number 4 of the Special Joint Committee on Medical Assistance in Dying. Pursuant to the orders of reference of the Senate Chamber adopted on February 26, 2026, the order of reference of the House of Commons adopted on February 13, 2026, the Special Joint Committee is meeting to study the eligibility of medical assistance in dying for those whose sole condition is mental illness. Today's meeting is taking place in a hybrid format pursuant to the standing orders. Members are attending in person in the room and remotely using the Zoom application, which I do see some people out there. I'd like to confirm that sound tests were made successfully. Before we continue, I would ask all in-person participants to consult the guidelines written in the cards on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including the interpreters, who we thank. You will also notice a QR code on the card which links to a short awareness video. I'd like to make a few comments for the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair, which is myself for this meeting. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raised hand function. The clerk and I will manage the speaking order as best we can, and we appreciate your patience and understanding in this regards. Now, I'd like to welcome our witnesses today for the first panel, which I think are all virtual. First of all, Dr. Christian Leon, Visiting Research Fellow, Center for Death and Society, University of Bath. And Dr. John Mayer, psychiatrist, Ontario Association for ACT and FACT. I don't know, John, when you have your time, you may want to explain what ACT and FACT is. Anyhow, Dr. Leon, if you'd like to commence, you have the floor for 5 minutes. I will try to make some sort of sign when you're about 30 seconds. I'll try to get your attention when you have about 30 seconds left. You can go a little bit over the time, but if you're finding yourself running out of time, you might try to get everything in time. You will have a chance, if you don't get through everything, to come back to it probably when there are questions. So, Dr. Leon, you have the floor for 5 minutes.
Thank you very much, and thank you for the invitation to appear, chairs and committee members. My name is Christopher Lyon. I'm Canadian and a family witness to MAID, academic staff at the University of York, and a visiting fellow at the Centre for Death and Society at the University of Bath. Since my father's death, I've researched and published on MAID. I speak as an individual. My dad, John Lyon, lost his life to a MAID provider in Victoria, BC in July 2021, 1 week after he moved into an assisted living apartment. With a low income, he was very anxious about how much assisted living would cost. The day he moved in was the first day of the record-setting but transient heat dome event that hit BC. 5 days later, potentially affected by the extreme heat wave, he fell in his new apartment. On day 7, as the heat dome broke, my dad received a lethal injection. When he found out about MAID, he told me a doctor told him he should have it. He was approved for Track 2 MAID for rheumatoid arthritis, frailty, recent falls, chronic pain, and conditions he'd often cope with. Halfway through the mandatory 90-day assessment period safeguard for Track 2, his providers labeled him Track 1, foreseeable natural death, and 3 days before he was killed. His medical certification of death indicates this track change was for early sepsis NYD. NYD is medical shorthand for not yet diagnosed. But the criminal code for both tracks first requires a person to have a grievous and irremediable medical condition, stating they must have a serious and incurable illness, disease, or disability. Track shifts like this won't be easy to see in the data Health Canada uses. When he first applied, I sent the local MAID coordinator a family document of collateral information detailing his history of mental health issues, including bouts of strong suicidal ideation, during life transitions like moving home. The heat crisis, combined with the move to assisted living, was absolutely in keeping with when he would struggle with his mental health the most. A few months before he died, my family arranged a call with the suicide prevention hotline, and he seemed to back away from this ideation, which was a recurrent pattern for him. The day he was killed was also the birthday of a family member who was present. I cannot begin to describe the horror. Dad's provider permitted him to drink wine both the evening before and day of his death. At the same time, he was prescribed prednisone, zolpidem, trazodone, and hydromorphone, all of which have severe psychotropic capacity impairing effects and which can mimic early sepsis markers and mental disorders. He had trouble remembering when or if he scheduled his death or even if he had been assessed. Get me out of here was the flimsy assent interpreted as his final consent. I pressed for a last-minute psychiatric assessment and was told the psychiatrist would just agree with the provider. They were right. The assessment was full of errors. It denied suicidality, minimized his history of depression, denied he was a smoker, and claimed he'd been living in his assisted living flat for a month, not 4 or 5 days. His provider told me he'd probably just kill himself anyway, and that she knew she was good at MAID because she'd never lost sleep over her deaths, and later told me not to raise my concerns. Attempts by his executor and me to file complaints and access his medical records, which might confirm or refute noncompliance, proved mostly futile. We only obtained a somewhat redacted copy of his psychiatric evaluation and his medical death certificate. BC's system is a pinball machine of deflections among colleges, police, and coroners, with records protected by privacy law that extends to deceased persons, though this does not seem to apply to the MAID providers who may use them for self-promotion and commercial ventures. If this is already the de facto standard of care for MAID, where mental illness and psychotropics are involved, what will happen if sole mental illness is permitted? In my research, I found evidence the charity, lobbyist, and constitutional litigant Dying with Dignity, or DWD, cares little for safeguards around people's mental health status, historically and now. A large body of archived evidence from DWD sources suggests that it ran a so far unprosecuted scheme of payment-based pro-suicide counseling, assisted suicide, and homicide of adults in the decades up to Carter and C-14, and potentially children. It hosted open access workshops on suicide methods amenable to assistance, homicide, and concealment from investigators. Its public website still describes alternatives for those who are ineligible for MAID, like stopping eating and drinking, refusing treatment, and options in Switzerland. This webpage is accessible to all, including those with mental disorders and children. Last year, Philip Nitschke, inventor of the sarcopod, who gives speeches alongside ChemApp's founders and DWD leaders at the World Federation of Right to Die Society's conferences, claimed in the British press that he provided material support to Kenneth Law. Law just agreed to plead guilty to aiding suicide in 14 deaths after facing first-degree murder charges. Nitschke claims to have met him at a more recent suicide workshop he ran in Toronto. Law's alleged victims were typically teenagers and adults with mental illness. So I find myself forced to ask very uncomfortable questions about what happens in those secret encounters with patients, despite all the MAID laws and safeguards meant to protect them from negligent care and unlawful death.
Thank you, Dr. Lyon. Dr. Maher, 5 minutes, please.
Bonjour. Merci beaucoup pour l'invitation.
Thank you for the invitation.
An Ontario hospital, a medical ethicist, editor-in-chief of the Journal of Ethics in Mental Health, and president of both the Ontario and the global associations of tertiary care ACT teams. They are the teams that take care of the very sickest mentally ill patients. For the last 23 years, I have treated patients that other psychiatrists told me could not get better, and yet they get better. Suffering can always be reduced. With dozens of validated psychotherapy modalities, hundreds of medication combinations, with myriad psychosocial interventions, there is absolutely no such thing as everything has been tried, despite what some patients say, and despite what some psychiatrists who lack skill, knowledge, or perseverance say. Death is being falsely presented as the only option. You seek my evidence because I have particularly relevant experience and knowledge. How do you know who is right when my statements conflict with others? Tragically, ableism and stigmatization are never defeated because of clear logical points made about social fairness. Ideology pays lip service to reason while amplifying misinformation. I presented on this same issue at a Senate hearing in 2021. My rage has since given way to profound sadness because the same misrepresentations keep being repeated by the same players. The issues have not changed in 5 years. The facts, however, have been made clearer. People are getting made for psychiatric reasons under the guise of flimsy medical excuses. Prolific MAID providers are happy to assist with suicides while people are on wait lists for effective treatment. MAID is being offered to veterans, disabled people, and people with very treatable illnesses. Irremediability is clearly known to be impossible to predict for mental illnesses, and patients will doctor shop until dead. Orwellian doublethink has been rampant. MAID activists say MAID is not suicide, that irremediable means you can't get better right this minute, that suffering is best relieved by death, and that the healthcare system cares about you so much it will help you kill yourself. People need lifeguards, not someone to push you under. Only 1 in 3 adults and only 1 in 5 children in Canada have access to the mental health care they need. The general public is not aware of this appalling and intentional lack of services. The Mental Health Commission tells us we could save billions by paying for upstream services that we know work. Instead, we let people get sick downstream, and it costs us billions more than necessary. Billions. So why don't we provide care that we know works and is extremely cost effective? And why are any of you supporting suicide instead of the care that prevents suicide? The answer is stigma, ableism, false economic claims, and a distorted view of autonomy. Please stop pretending autonomy is some detached, rational enterprise. Very sick people are actually driven by fear, desperation, and hopelessness, born of the illnesses we undertreat and don't treat. If you have to help someone kill themselves, then they are not acting autonomously. I am tired of the farcical news story citing people who have been trying to kill themselves for decades and are demanding that a doctor help them. There is a laughable conceptual distinction put forward by MAID activists that MAID is well thought out and true suicides are impulsive. Decades of suicide research put the lie to this. 80% of suicide attempters thoughtfully plan their suicides. MAID is suicide par excellence, like having a wedding planner to make it all as easy as possible, even with same-day service. The Harvard School of Public Health showed that 90% of people who attempt suicide do not go on to complete suicide following treatment. With the right treatment, suicidal thinking disappears. The rates of suicide in jurisdictions that have MAID, specifically Oregon, Switzerland, Netherlands, Belgium, and Australia, have risen much faster after it was legalized than before. Suicide contagion is a well-proven reality. Don't pretend it won't happen in Canada. 72% of Canadians oppose MAID for mental illness. Over 90% of psychiatrists are opposed. You should listen. But mostly you should stop and try to imagine what it is like to be given up on. If you have never tasted raw, hopeless despair, then stand boldly behind the claim that we should all be entitled to suicide facilitation. But if you have known suffering, the suffering of those you are inviting to death, then you can't pretend that this planned social travesty is anything but accursed ignorance. Merci beaucoup.
Maher. For the first round of questioning, I go to Mr. Lawton for 5 minutes.
Thank you very much, chairs, and thank you, witnesses, for your testimony. I'd like to start with you, Dr. Maher, just to put a fine point on this. The MAID regime we have in Canada did not exist as a healthcare policy. It is an exemption to murder in the criminal code. So when you describe mental health as already qualifying people in the eyes of some assessors and practitioners for MAID, you're describing criminal misconduct, are you not?
I absolutely am. I had a patient with schizophrenia who was approved for MAID on the basis of a skin condition that a dermatologist said could be treated with a cream and a sore ankle following not cooperating with physiotherapy after a broken ankle. I had a fierce argument with the MAID provider who said that was sufficient. My patient had schizophrenia and was psychotic and delusional at the time. That is what's happening. These are already happening.
From your understanding of the case of Keanu Vafayan, which was reported in media, would that fit the bill of what you're describing? Someone who was dealing only with a mental illness and had a very flimsy physical condition appended to justify MAID?
I won't comment on the particular case. All I know is from the media. But I do stand by my statement. I and other colleagues are experiencing this. People are clearly getting MAID for reasons that are, frankly, illegal.
We have heard a variety of views from psychiatrists before our committee thus far, and somewhat counterintuitively, we have psychiatrists saying that there's a general consensus that mental health conditions can be irremediable, at the same time as other psychiatrists saying that isn't the case, which proves there is no consensus on this. So explain to me how you view irremediability in the context of mental illness.
I certainly don't view it the way MAID activists have meant be tried first. Is a fine safeguard, but then it begs the question of what are standard treatments. I'm a subspecialist psychiatrist. I'm a psychiatrist. People get referred to me who other psychiatrists say can't get better, don't know what to do, and they get better. There is, irremediable. We're talking not about cure, although I have patients that we could easily say they're cured. In the sense that diabetes is cured if you take your medications for the rest of your life. It will have no significant impact on the quality or longevity of your life. So that certainly happens all the time in psychiatry. Do I have patients for whom symptoms persist? Absolutely. Do I have patients for whom symptoms can never be ameliorated? Never, not once. And I stand here representing the 70 ACT psychiatrists who do this subspecialty work in Ontario. There are always ways to reduce suffering. And I don't mean to be, break the rules of the club, but not all psychiatrists are subspecialists. Yeah. Not all cardiologists are cardiac surgeons, right?
Thank you. When you talk about suicide contagion, I just want to make sure I understand the point you're making. Are you saying that just by the act of permitting this, if that's what Parliament chooses to, well, already has done, but if that's what proceeds, that will basically normalize or legitimize suicide as an option for people who might not avail themselves of MAID, but may just commit suicide on their own because the government has basically said this is a legitimate answer to mental illness? Is that what you're saying?
Yes, the Werther effect, a well-known phenomenon, which is why newspapers agreed not to publish articles about famous people and how they killed themselves. And yet we have made articles in the press daily. I had a patient today, schizophrenia, very, very cavalierly saying if he didn't get a job and a girlfriend, he's going to request MAID. It's been normalized. It's suicide contagion is a well-established phenomenon. And we didn't start looking at this data until the MAID legislation, euthanasia program started emerging in some countries. The rates of the countries I named where, their rates have gone up and the countries around them have gone down, it's a very, very legitimate, significant concern. It's modeling, right?
Thank you. Thank you, Dr. Marr. Just very briefly, Dr. Lyon, when you talk about conversions and people going from track 2 to track 1, the lack of Health Canada having adequate data on that would in and of itself indicate there is no readiness to expand track 2, correct?
It's a good question. I don't think there's any ready to expand track 2. I think that right now, based on my own experience, if we're able to track shifts like that and record deaths that have been moved for reasons such as undiagnosed illnesses, and those are showing up as track 1 in the data, we really don't know what is really a track 2 case and what was really a track 1 case in that. So it would be very, very difficult to expand under those circumstances.
Thank you. Dr. Jacek for 5 minutes, please.
Thank you so much, Chair, and thank you to both witnesses. You've certainly made your positions exceptionally clear on where you stand, and as has been referenced, of course, we have heard from other psychiatrists and experts in ethics and so on, who feel differently. So from your point of view, Dr. Maher, if MAID were to be approved in our country for the sole underlying condition being a mental illness, what kinds of safeguards could you envisage might be reasonable in such a situation? Or are you completely saying it's impossible to have any safeguards?
I am saying safeguards are going to fail because the cultural ethos, the suicide contagion, is already permeating our society. My teams are pulling their hair out over people planning to refuse medications so they can get made, people who have healed and recovered. We're doing suicide prevention, and people are being presented with, suicide is coming. Safeguards, standard treatments being tried that the Benelux countries do, then it begs the question, what counts as standard treatments? Because I'm subspecialist care. I have literally limitless options. And it's because of that my patients get better, because we can continue to try. My patient, the average treatment time for me to help people recover from severe schizophrenia is 3 years. It's not a short process. It's like a long chemotherapy protocol for people with certain types of cancer. How do you maintain hope in the face of that? I have a patient, a family doctor, I'm in the middle of treatment, came and offered her maid. And she said, oh, thank goodness my family doctor cares enough about me to relieve my suffering. I want to relieve her suffering by treating her. And she was 35. So are there safeguards? Either the fundamental value question here is either you support suicide or you don't. If you're opposed to suicide, if you think the suicide taboo provides protection, if you think there's merit in supporting life, clearly my fundamental argument here is provide the basic services. I work in an ACT team, right? Subspecialist teams caring for the sickest. There are 80 in Ontario. There should be 150 by population. So right now today we have 5,000 people waiting for the care for their illnesses that are degenerative illnesses. They're going downhill, waiting up to 5 years. If I asked you in the cancer field, would you be okay with funding 60% of the cancer centers and letting everybody else kind of flounder and hopefully live? So safeguards, I think, are fanciful given the clinical reality. And this is my great frustration. I can stand here and say to you, you don't get what it's like on a daily basis. I don't know if I'm the only person in the room who spent yesterday listening to a patient in emergency tell me why she took an overdose. I don't know if I'm the only person in the room who's listened to thousands of people after the fact tell me why they wanted to kill themselves and the help they wish they had had. And offering suicide before they get the help,
Dr.
I don't
Maher,
know how you can do it.
I'm sure you're an extremely compassionate physician, but have you not had your own patients commit suicide?
Of course I have.
And
The suicide rate for schizophrenia is 10%. The suicide rate when people are in ACT teams, under 2%. What does that tell you? Like I said, the Harvard stuff, and there's Canadian research, the Canadian Suicide Prevention Society, we know treatment prevents trying again. 4,000 people in Canada will kill themselves this year. Those 4,000 are only 7% of all the people who tried. That means 93% of people didn't try again. Why is that? When you're in crisis, you get the help. What frustrates me profoundly is get the help long before you get to that crisis point.
We had,
when I say,
excuse me,
Sorry.
we had a psychiatrist here who absolutely agrees with you in terms of MAID should never be allowed or considered irremediable unless the person is not in crisis. That obviously, if they're in crisis, this is not the time to make any such a request. Do you think that's at least a reasonable position?
So rational suicide is absolutely a thing that occurs. There's no question. And the majority of people have capacity, right? They're able to make their own treatment decisions. But if you're making a decision at a point in time when you are still suffering and can't get help, or you don't believe that help is going to be possible, or you're fed up and tired of it, I understand that. But look at the 4,000 suicides in Canada this year. 90% will be people with mental illness. 90%.
Thank you, Dr.
So yes, there's rational suicide. But why do we have to help people kill themselves if they can do it themselves? And I don't mean to be callous.
Maher, Mr. Thériault, vous avez la parole pour 5 minutes.
Mr. Terrio, you have the floor for 5 minutes. Thank you, Mr. Chairman. Dr. Maurer, I understand your frustration. Mental health, mental illness have often been the poor relatives of our healthcare systems for many years. But other than the fact that I commiserate with your frustration and the suffering you see every day that's expressed before you, what bothers me in your testimony tonight is that psychiatrists who have other opinions than yours are incompetent. I'm not a specialist, I'm not a psychiatrist, I'm not an expert in mental disorders, but it seems to me you have to look at things in a balanced way. We have the Canadian Psychiatric Association. They're not all incompetent people in that association. And now they are making clinical recommendations on MAID, evaluation of irremediable and grave situations of people with mental disorders asking for MAID, and the management of suicide risk during the process for requesting MAID. These people are saying they could provide training on these delicate points that you've raised. They claim that while taking into account structural vulnerability and faced with a case where vulnerability is the main reason for the request, it seems to me that not all the expert groups were full of incompetence. There are people who are saying it's not a matter of continuing the discussion of MAID when there's a suicidal ideation. But I'm sure you've read this report. There were many precautionary principles to avoid the apprehensions you have and the situations you're denouncing here tonight. Who am I to believe? Is anyone who doesn't share your opinion an incompetent, as you have said?
My translation was set up at the initial point of contact, but it's not been working. Donc, je vais essayer de vous répondre.
So I'm going to try to answer. I'm sorry, Madam Chair, one moment, please. Just a moment. We must indicate to the witness there is a way of hearing the interpretation, and I demand that I do not waste my time with witnesses who were not given these explanations at the outset to hear what I had to say. This is the first time that has happened here, but it has happened before. So I would like us to indicate to the witness how he is supposed to listen to the interpreters. We can't have a discussion on sensitive issues like this if we cannot understand each other. So I'm expecting you to stop my time, and I would like to have the interpretation. I will stop your time, and I will explain to Dr. Mayer.
This, or do we get the? So on the bottom of the screen, Doctor, and we're going to give Luke his time back so he can ask his question again, so you fully understand. But at the bottom of your screen, you can select the appropriate channel for interpretation. Do you see that? Joint the audio.
Under audio?
Yeah, and then you can select. We'll suspend for a moment until we.
Is it under audio settings?
here.
Luke,
Dr. Maher-
je vais être...
Luke, I will give you the floor again. You can put your question again. Okay. Well, since Dr. Mayer says he understood, we'll start the discussion with this time with 5 minutes. Yes, we're going to start with 5 minutes. Okay. So go ahead, Dr. Mayer, since you apparently understood my intervention. And if that's not the case, I will tell you and we can start over. Yes, you'll certainly correct me.
In describing colleagues, what I said was colleagues who lack skill, which a young psychiatrist would, as residents do, lack knowledge. I'm not an expert in anorexia. I'm an expert in schizophrenia, bipolar disorder, schizophrenia. So we all lack knowledge to some degree in some areas of our broad area of medical psychiatric care. I also said lack perseverance, and that, I think, is a key point to be made here. I am, as a subspecialist psychiatrist, like a subspecialist in any area. If I have a complicated cancer, I'm off to Princess Margaret Hospital in Toronto. I'm not at my local hospital in Barrie, right? So that's partly what I'm talking about.
Je comprends.
But the perseverance of care.
Alors,
Okay.
vous considérez
Yes,
que...
I understand. You feel that there are people who don't have your skills or competence. I refer you to a document by the Canadian Psychiatric Association. Have you had to do an assessment of a patient who requested MAID?
Est-ce que vous avez suivi
Have you had any training from the Canadian Psychiatric Association when it comes to evaluating the eligibility criteria? Do you feel that this document is full of incompetence? Do you feel that at the outset one cannot assess a patient, according to your view, that it's impossible to do so?
Understanding of the capacity assessment you're talking about. You're not assessing whether someone is eligible for MAID. You're assessing whether they understand and appreciate the consequences of refusing psychiatric care. And if they understand that, they're free to do whatever they want. If they want MAID, they're free to request MAID. The capacity assessment...
C'est pas... Excusez-moi,
I'm sorry. I'm interrupting you, but that's not what the expert group report says. That report indicates quite clearly that it's not because somebody raises their hand and says, I want MAID, that they'll be automatically eligible. They may be eligible, but there is a series of principles and precautions that are stated here and that are considered in the report by the expert group. And therefore, it's not true that it's sufficient to refuse treatment to be eligible for MAID. It's quite the opposite, according to this report. If you're an expert in schizophrenia, or if you cured all the patients who presented themselves to you with schizophrenia, you really deserve a Nobel Prize in medicine. But schizophrenia is a disease that is not easily treated. So it's possible that one patient after 30 years has enough because he has not had his suffering relieved. Here we're saying it's not a matter of saying that a person who is in a suicidal state should have access to MAID. So decision-making capacity seems to be one of the specialties of psychiatrists, and some of your colleagues are telling us that it's totally possible to do things within the rules, and you are claiming that's not possible. But I do agree with you that we need more resources to treat people. We have to be even more proactive. But those are two completely different dimensions. These are two completely different problems. We're talking here about somebody who's at the end of their tether. Are we to maintain him in palliative care Forever? Because that's all you can do? Because you cannot cure that person?
You said two things that I didn't say. I didn't say that if you're found capable, you're eligible for MAID. I did not say that, and I am an absolute expert in capacity assessment. So the logical distinction I make is valid. And I am saying the CPA has some things wrong about capacity. And if you look at the capacity literature, you'll only get about 75% agreement. And if you've got 25% of psychiatrists saying capable, not capable, that's a problem. That's an operational problem. So when the CPA says we can do this, it's a claim that is not defensible, because if you're mistaken here, if you say someone is capable and they're not, and lots of people pretend to be quite rational and can manage it for a while, which is why expertise matters, which is why relationship matters. So you've said two things I didn't say. And
Okay, thank you.
in terms of long-term suffering...
Thank you, Dr. Maher. We have to go on. Senator Delphine, pour 3 minutes.
3 minutes, Senator Dalphon.
Dr. Maher, I'm interested in data. And you referred to some data, but I would like you to provide me support for it. You said 93% of psychiatrists are opposed to MAID for mental illness. Where do you get that number, 93%?
So that was an OMA survey, and 90% are opposed without standard treatments at least being attempted first. We don't know, as far as I can tell, there's no recent data saying what the absolute opposition is, because there have not been continuing surveys. And the data I provided about Canadians being opposed, that was an Angus Reid survey.
Okay, so but you said 93% of psychiatrists, not Canadian. So I mean people that are that are supposed to be able to evaluate or assess capacity. So you said that number is coming from a survey?
Yes, the Ontario Medical Association survey.
Okay, so could you provide...
And so a survey is never everyone.
Okay.
It would be hundreds of people who responded.
Okay, could you provide a link that we could have access to that survey?
Certainly.
And I understand from your answer that the survey was that they should not have access to MAID unless they have tried things. Isn't that what you said?
Unless standard treatments have been provided.
Okay, so, and what is the question, what was the answer about the question, if standard care is provided and treatment for a few years, was that asked to the psychiatrist that if they are still opposed at that time, access to MAID?
No, it wasn't asked, but the question was asked how many people support MAID for mental illness, and the answer was only 3%.
Okay, without the treatment. And you said that the other thing is that the rate of suicide is increasing in jurisdictions providing access to MAID for mental troubles or illness. So which data are you referring to?
There have been about 5 studies published at this point. Jones would be one of the obvious authors, has done research on this. And it's recent research because it was prompted by MAID and various countries starting euthanasia programs. So it's solid data.
So would you mind to provide us the copies of these 5 studies you rely on?
Certainly, happy to do that.
Thank you. Did you have time or?
You have 24 seconds.
Well, then I thank you very much for your answers.
Senator Martin for 3 minutes.
Waiting for my mic, but I'll turn it on. Thank you both for your testimony. My first question is for Mr. Lyon, Dr. Lyon? Dr. Lyon. So you explained what happened to your father, and I think it's important for us to understand what happened. And you said your family had difficulty getting a MAID clinician to consider the collateral information you tried to share about your father's mental illness. So based on this direct experience, can you tell us what that revealed to you about how the current system handles mental health evidence, and why should that concern this committee as it's examining whether or not to expand MAID for those suffering from mental illness as a sole underlying condition?
So my impression from that experience was that the providers in question, I got conflicting answers. So his maid provider seemed to suggest that his suicidality was a reason for MAID. And the conversations we had, as I mentioned, she suggested that, he might just kill himself without MAID. Suicide is more plausible now, things like that. But then when I had broached the prospect of his depression, she also told me that if he had depression, he would be ineligible for MAID. So there was I didn't quite understand that conflict in those comments between, okay, if he's got depression, he can't have MAID, but, it's okay to be suicidal. So if you look into the way that the Right to Die movement frames this, they have this idea of rational suicide, and they'll start to make a separation there. But then when it came to a psychiatric assessment, his provider said that the psychiatrist would just agree with them, but the psychiatrist also said it talks about his depression in the assessment, but it said it sort of quotes my father saying something to the effect that it's very minimalizing language, right? And then it goes on from that. But the assessment itself has been described as global to me and subpar. So there was this almost a conflict between what the psychiatrist was exploring and then the different statements that his provider said to me. So it was very confusing. And so when we look at MAID for mental illness, you're going to get divergent views among individual clinicians. And when I think about, as the law is written now, as I understand it, if it comes to pass in 2027, it won't be psychiatrists doing the assessments for mental health cases. It will be the same nurse practitioners, general practitioners, anybody else a medical practitioner or a nurse practitioner who is able to do these assessments without any training as it is. So when we move into that space, we don't have any coherence.
Thank you,
Yes, so that
Dr.
inconsistency.
Lyon.
Thank you.
Senator Martin, I'd like to welcome Senator Lafreda to our committee, and you have the floor for 3 minutes.
Thank you, Mr. Chair, and thank you to our doctors, our experts for being here this evening. So my question is around defining incurability in mental illness. And Dr. Mayer, you went deeply into it, and I'd like to have Dr. Lyon's expertise on this if we have time. There remains significant disagreement as to whether and how a mental disorder can be considered incurable. I mean, that's a very important question. And does the current, maybe elaborate on this, does the current clinical and legal definition provide sufficient clarity to ensure consistent assessments, or does it risk subjective interpretation that could lead to uneven or unsafe application? And I say that, and I put that question forward because, Dr. Mayer, you made some serious claims there with respect to suicide or mental illness, if they were allowed or not allowed to it. And I come from an industry where integrity is never negotiable. I think I've said that a million times. So, but we don't have any doctors that were reported or what have you. So, how much? Maybe you have your opinion on that, or your judgment on it. More importantly,
You're asking me?
yes, Dr.
Excuse
Mayer,
me.
go ahead.
Yes, I tried reporting a doctor to the college of one of the provincial colleges and was told, until the patient is dead, there has been no malpractice. And I said, the assessment has come to a conclusion, the doctor has come to a conclusion that is flat out illegal. There were no criteria on any stretch of the imagination that would qualify this patient for MAID. The family doctor and I both told the MAID provider this. And the college said, until the person is dead, it's not malpractice. And I said, well, this person is being induced to a suicide plan, has been given the belief that they will be killed, and they were offered their date to be killed. And the college said, we will do nothing. So I have tried, colleagues have tried, and that's what we hit our heads against.
So you don't. You believe the tools, protocols, safeguards in place are
are faulty or they could be improved in making the distinction.
I am aware of murders that have taken place in Canada for which there was no follow-up. The police have the door shut because the hospitals say it's confidential medical records, and the college, I won't say all colleges, but in my experience and other colleagues, there is not action. There is not a taste for this. Yes, I'm aware of homicides.
That's very concerning.
sorry.
And it's even
You only have about two seconds left. So
2 seconds.
If you don't mind,
I don't have that much talent. I work hard every day, but I
So
don't
unless
have
you
that
drink
much
lots of coffee, you're not going to get it in there in time.
Thank you.
So Senator Wallen for 3 minutes.
Thank you very much. My question is for Dr. Lyon. I read from your professional credentials that you are with the Department of Environment and Geography, and you also work in the field of biodiversity. Is that correct?
That's correct.
Do you
That's one
have
side of
any
my job.
formal legal training or training in policing or in constitutional law?
No, I don't.
Okay. The reason I'm asking is because you've authored and published a paper called Canada's Medical Assistance in Dying System Can Enable Healthcare Serial Killing. That is a very serious allegation to accuse medical professionals of being serial killers. What was that professional opinion based on when your area is neither medicine nor law?
Several things. So one thing I am is a researcher. What I can do is research. So when we look at the definition of serial killing that law enforcement services put out, it's quite simple. It's usually something along the lines of killing 2 to 3 people in sequence on separate occasions or separate events. That's serial
And you
killing.
think that is applicable in the medical profession?
When we created, so the difference between let's say criminal serial killing and MAID is that we've created a carve out in the criminal code for medical professionals who engage in discrete.
No. There are
homicides.
standards and eligibility requirements for the
finish,
provision of MAID. There's no such situation for serial killers. I mean, let's be realistic here.
So what you're speaking about there is basically a definition in law. Okay, so criminal serial killing is killing outside the law.
Right, and this
When
is
you're
not
killing in
outside
MAID,
the law,
fitting
which is the
definition of
distinction I'm
serial
trying
killing,
to make clear here for
you
people
are
because
creating a legal form of serial killing in MAID because you're creating an opportunity
MAID is actually
for MAID
legal, right? You understand
Yes, it
that
is.
according
I'm saying
to the
you're
Supreme
creating
Court?
a legal form of serial killing. What I'm not saying right now in MAID is serial murder, which would be illegal. So in serial killing, MAID is still a form of serial killing. So if you kill 1, 2 to 3 or more patients sequentially within the law, you are still committing serial killing within a legal parameter.
So if you
by that
misdiagnose a person, or if the cancer moves more quickly, or if the mental illness can't be diagnosed, you're saying any medical professional could be actually accused of this. That's your position.
That's not my position.
Well, MAID is actually legal in Canada. It was
I know,
declared
that's what I'm
legal by
saying.
the
It is
Supreme
still-
Court and Parliament.
If you take the basic definition that law enforcement uses for serial killing, before you add whether it's criminal or not, either whether it's within the law or not, you're talking about the difference between a culpable and a non-culpable homicide. MAID legally is a non-culpable homicide. So a series of MAID deaths that are within the law are a series of non-culpable homicides.
Thank you, Dr. Lyon and Senator Wallen. Senator Wells for 3 minutes.
Yeah, I'm going to continue what my colleague has just been talking about. It's both of our witnesses today have made some pretty serious accusations of doctors being murderers. This is, if this is so extreme, the committee needs to see proof before those accusations can be part of the public record. So I'm just going to put that out there. Dr. Mayer, are you aware of the 2026 Environics poll for support of MISUMC? The poll question states, under Track 2 safeguards, do you support or oppose allowing an adult with the capacity to provide informed consent to seek an assessment for MAID, and if eligible, receive MAID when their only medical condition is a severe treatment-resistant mental illness that causes enduring and intolerable suffering. Are you aware of that poll?
I'm not.
Okay.
I'd like to clarify.
Thank you.
I didn't call anybody a murderer.
Oh, thank you.
Homicides.
That's not my question. Right now, the poll, so 80% of that poll agree with that assessment, agree with that statement. That's public opinion. That's actually on the record. You've also said in your May 2022 testimony before this committee, you stated, "We have yet to find a case where treatment and recovery were not possible. Yet we've heard from multiple witnesses at this committee that we should treat persons with a mental illness similarly to how we treat persons with disability." Understanding that, is it your professional opinion that all people with mental illnesses will get better?
No, it's my understanding
thank
that
you.
all people with mental illness can have their suffering reduced.
Thank you.
And can be supported
My
to the
time
point
is
they're
limited,
no longer
unfortunately.
suicidal.
I think you posed a very lengthy question. I would give the witness a brief opportunity to reply.
It was
to
a
the
yes or
question.
no question. Thank you.
Chair,
Are
no,
you
we're
gonna
not going there.
point of
Dr.
order?
Maher, you have 10 seconds or so to answer the question.
Thank you. I'll just repeat my answer. Suffering can be reduced, and people can receive treatment that can reduce their suicidal thinking, goals, and plan. They can find meaning and purpose with support. And yes, that's true of 100% of people.
Thank you. Dr. Lyon, so my question is, have you ever personally assessed a person for MAID?
No.
So what you're sharing is your personal position, which seems to emphasize protecting vulnerable individuals. But how would you respond to concerns that denying access to MAID for competent adults is inherently paternalistic and undermines their autonomy and dignity?
I've never made that argument here.
I'm asking you how you would respond to those concerns that we've heard before this committee.
Well, MAID came about through Carter, so it's a constitutional decriminalization, basically, right? And then we have this lower court ruling in Quebec. So within those parameters, and the parameters set out in the legislation, provided those are met, that there's not much room for argument on that. If I have a personal opinion on what I think is happening, if that's what you're asking me for.
Okay, thank you. Sorry, we don't have time for that personal opinion, but Mr. Cooper, you have the floor for 3 minutes.
Thank you, Mr. Chair. Dr. Maher, just to follow up, you indicated that a 35-year-old patient who had severe mental illness was offered MAID by a family physician proactively. What happened to that patient?
She died of an unexpected medical condition before the MAID date.
Okay. Now, I want to follow up.
But she had purchased her ticket and was ready to travel, and her parents were going out of their minds.
Okay. Now, you you indicated that you are aware of and you have reported homicides that were carried out under the guise of MAID. Can you elaborate on that?
So I haven't approached the police. I have dealt with one college in particular. I also sought the assistance of my professional association's lawyer, and was surprised to discover that the Canadian Medical Protective Association now has 4 lawyers whose only work is to deal with MAID issues that doctors keep bringing up for them. And the restrictions on what we can do, given the limits of confidentiality, are extreme. And the best I could do was go to a college.
And when you went to the college, what happened?
As I said previously, I was told until the patient was dead, there can be no malpractice. And the clear tone of the conversation was, we're not going to do anything about MAID because the legislation is so broad that it really is a matter of individual clinical judgment whether someone thinks that the criteria are satisfied. And because it's a subjective standard, no objective standard, if someone says they've suffered enough, that's enough.
we've heard in this committee documented cases of abuse under the MAID regime that have been cavalierly dismissed as anecdotal. What do you say in response to that?
Well, I'm not talking about anecdotal experiences myself. These are direct experiences with MAID impacting my patients, impacting my teams. And it's not even legal for mental illness yet. And it's already had profound disruption in terms of undermining our efforts to maintain hope and to provide treatment for recovery. It gives people the message we've given up, right?
14 seconds.
Can psychiatrists accurately distinguish between suicidality and a rational request for MAID, yes or no?
Suicidality and a rational request for MAID. No, MAID is suicide. It's taking steps to arrange your own death. MAID is suicide.
Thank you, Dr.
It's an artificial distinction.
Thank you, Dr. Maher. Ms. Koutrakis for 3 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for appearing before us this evening. My question is to Dr. Lyon, and my understanding is that you do research also internationally. So I'm interested to know, when you're doing your research across, how assisted dying develops across different countries, could you walk us through a specific example where eligibility expanded over time and what actually drove that change in practice?
I don't do research across jurisdictions on MAID. I focus mostly on Canada. There's been some work on the Netherlands, for example, in Belgium. I think people like Trudeau Lemons or Scott Kim might be better placed to answer how those systems evolved.
And in your research in Canada, have you seen or heard any professionals talk about safeguards that may have looked strong on paper but didn't potentially do what it was intended to do if put in practice?
I think quite a few of them have come before this committee.
Dr. Mayer, do you have something to add to that? Through your experience, your practice, what you have seen through your patients or research data?
In terms of expansion to other countries?
Yes.
Well, I've been involved in conversations with people in other countries many times looking at these issues. If you're asking why is it expanding, some of the more interesting questions is why doesn't it happen in any of the Asian countries because of the values and perspective they have there? Why was it recently overturned in Slovenia? Why did the Scottish Parliament object? Why have we seen the kind of the chaos in the British discussions over this issue? It's a values question. I think fundamentally you either support suicide prevention and helping your citizens live and heal and recover, or you don't. And so I have little more to offer than that.
Because I was touched personally by someone's story where their parent became blind and deaf and had requested, this played a huge issue on their mental illness, and they had asked for MAID and it was rejected. And as a result, this person took matters in their own hands and they jumped off a balcony. Would you agree that every Canadian deserves a dignified death?
Yes, but we have different definitions of dignity. Yes, but we have different definitions of dignity. The greatest dignity is to have your autonomy restored and to be able to continue to live. The argument that somehow a messy death justifies supporting suicide misses the point completely. What it justifies is treatment to prevent getting to a messy death or MAID in the first place.
Thank you, Dr. Maher. Mr. Thériault, pour 2 minutes.
Mr. Thériault, 2 minutes. Mr. Thériault, we cannot hear you. I'm used to being in the room. My question's for Dr. Mayer. In bioethical literature, there is history about end-of-life care. We went from overtreatment to recognition of right to die, because palliative care is a recognition of the right to die. We used to call this passive euthanasia, and we heard about the same arguments about passive euthanasia as what we're hearing tonight. So we went from medical paternalism, which imposed overtreatment, to recognition of right to die for the patient through palliative care. It was recognized, therefore, that a patient could have care for comfort, and a little later we arrived to MAID with the respect for autonomy that we wanted to give patients. A patient can decide on their own death in a situation where they're terminally ill. I hope you're for that. So that respect for autonomy and self-determination of a suffering person led us to sound medical practice, which consists in recognizing refusal of vital treatment, cessation of treatment when it's futile. So I'd like to know, what do you feel about end-of-life care, medical paternalism? And you seem to feel this way, at least when it comes to psychiatry.
Right. So I'm one of the earliest formally trained bioethicists in Canada, so I know the literature well. And I've watched the pendulum swing around paternalism, and I have greatest respect and gratitude for that. We should be free to make our own decisions. And here's what it comes down to. I am free to kill myself. Why am I entitled to ask anyone else to do it for me? And if you say, oh, we have to provide compassionate care and support, I know patients who bring their families to their home with planned suicides, and they don't need a doctor to do it. So there's some sort of artificial claim here that when we bring a doctor in, it makes it better or prevents errors or all of these things. The paternalism here is saying you have to have a doctor to do it. But let me make this critical point. If you're not willing to kill yourself without a doctor helping you, that means the doctor is responsible for suicide inducement.
Thank you, Dr.
It is
Maher.
facilitation.
Thank you, Dr. Maher. Senator Martin for 2 minutes.
Okay, not much time. So you were talking earlier about just the concerns that what gets called autonomy can sometimes be a response to abandonment, poverty, isolation, and lack of support. So this is a question to Dr. Mayer. If assessors are already being trained to focus narrowly on consent and capacity, how can Parliament trust the system to safely handle cases where mental illness will be the sole underlying condition? So would you further expand on your sort of what is happening right now with the system?
Certainly, it's a nuanced discussion. We treat people like they're Mr. Spock in the literature in our discussions of capacity. They're not. They're messy. They're driven by emotions and despair, hopelessness. The very offering of MAID is a message in that point in time that I haven't got anything else for you. So the undermining of the clinical relationship by the very offering of MAID is profound. And unless you're living it and experiencing it, I'm not sure how to communicate what it means to rob people of hope, especially when they're having to struggle over time. Monsieur Thériault talked about, am I going to make somebody suffer for 30 years? If they've lived for 30 years, they've been living a life. And what has that life been for them? So to say that they shouldn't have had those 30 years, they made a choice to live. Autonomy is my choice to do what I want with my body. I can kill myself. That can sound callous, but it's not. People thoughtfully plan their own deaths. I can tell you stories of how people plan their suicides. And if you have some fantasy that everybody does this horrible, impulsive thing, it's uncommon. It's about 10% of people. And to be clear, the impulsivity is not genuine impulsivity. They have rehearsed it in their heads for months. We have research showing that. That's autonomy. I can do what I want. I'm objecting to the system being set up to induce, to seduce, to invite, and to rob people of hope. That's not what we as a country should be doing to the vulnerable.
Thank you, Dr. Mayer. Last of all, Senator Lafreda for 2 minutes.
Thank you. So, Dr. Mayer, thank you. We don't want to rob people of hope. I mean, we all need hope. But my question to you, and Dr. Lyon, if you'd like to bring in his expertise, if we do have the time, given the inherent uncertainty in these assessments, would you agree, or with an additional national safeguard, such as a mandatory specialized second opinion, to ensure consistency and protect the vulnerable individuals? And I think data oversight and public confidence are so important, and public trust in this regime depends on transparency, consistency, and the ability to monitor outcomes in real time. The current data collection, what I gather and what I've heard this evening, is not sufficient enough to capture the complexity of these cases, including the unsuccessful requests, the reasons for refusal, and indicators of vulnerability such as lack of access to care or social supports. I mean, what's your experience and judgment on that?
Psychiatrists have biases. There are reasons that some psychiatrists are strongly in favor and happy to do MAID assessments. We come with biases. If you're asking what the data says about capacity assessments, it's very easy to sort out who's extremely psychotic or profoundly depressed. Very easy. It's very easy to sort out who's doing really well and is quite capable and rational, which would be the majority of people. Right? What's complicated is the gray zone, and the gray zone is substantial because the data will say about 75% of psychiatrists will agree on what they're seeing. And if you have 25% disagreeing, that's pretty significant. I frankly view the capacity issue as a red herring. I've thought this for a long time. People are focused on, we got to decide whether they're able to decide. That stuff is done every day in psychiatry, every day, and it's called a capacity assessment for treatment decisions. And insofar as you're calling MAID a treatment decision, then this fits into that category. To say it's somehow special or different is, in fact, does not reflect the reality of the day-to-day work of mental health care. Are people better at doing capacity assessments than other people? Absolutely. I have, if I've got 40 years of experience versus I'm a fresh grad, I'm going to see things differently.
Thank you, Dr. Maher. Thank you, both Dr. Lyon and Dr. Maher, for your time. We'll briefly suspend while we get together in the next panel. Call the meeting back to order. Point of order, okay.
Mr. Chair, we lost about, I think it was 11 minutes in the first panel on the technical issue. We're about 20 minutes over now. I just was hoping you could confirm when we have resources until and whether we'll have all rounds of all remaining panels.
We discussed it.
We have a play of up to 15 minutes, but I can ask for a few more minutes to be available.
We have generally up to 9:45, and we'll try to be done by then. I think we might want to curtail a bit the last panel, just to get all the testimony. Is everyone in agreement on that? I think we all want to finish as close to 9:30 as possible. I mean, so hopefully everyone will be in agreement, if necessary, to everybody cut back a little time on the third panel, if necessary. But we have up to 15 minutes. What's that?
Shortchanging the third panel.
We could, if
think that's
everyone's
fair.
in agreement on that. I mean, we could cut everybody by 10 seconds, say, for the next panel as well. Off everybody. Is everybody agreement on 10 seconds right across the board?
Yes, keep it equal.
I'm not on it, so sure.
Is everyone okay with that? We'll take off 10 seconds and hopefully off everybody, and hopefully that'll get us closer to getting it on time. Okay, we're still in session. So I've been asked to quickly read this again because of the question previously with someone not understanding the translation process. So I'd like to confirm that sound tests were made successfully. Before we continue, I would ask all in-person participants to consult the guidelines written on the card on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including the interpreters. You will also notice a QR code on the card, which links to a short awareness video. I'd like to make a few comments for the benefit of the witnesses and members. One, please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. With that, I would like to welcome our second panel. We have Gabrielle Peters, co-founder of Disability Filibuster, as well as Catherine Fries, Professor Emeritus, School of Disability Studies, Toronto Metropolitan University. They're going to be sharing 5 minutes. Dr. Michelle Hewitt, Board Chair for Disability with Poverty, and Krista Carr, Executive Chief Officer, Inclusion Canada. We'll start off with 5 minutes to Ms. Peters and Dr. Frazee. I think, Ms. Peters, you're going to go first. And my understanding is that because of some medical problems and problems with breathing, that we may have to go beyond the allocated 5 minutes. So we'll give you a bit of leeway. But if you'd like to start off, Ms. Peters, and I believe she has a video. What else? A video?
The video is for Madam President.
No, I'm speaking live.
Oh, okay. So Dr. Frazee is going to have a video. So, Ms. Peters, go ahead. So we're trying to fit you both in as close as we can. 5 minutes. Go ahead.
Okay, I'll do my best, but I appreciate the accommodation, disability accommodation. Thank you. One of the hats I wear is I sit on the Providence Healthcare Psychiatry Lived Experience Research Advisory Committee. And I am always struck by the urgency accorded expansion of MAID for mental illness versus that of providing funding for comprehensive mental health care, supports, services, a livable income, and housing for those with mental illness. Injustice can often be measured in time. We know that neither people nor policy are islands, unto themselves, and yet MAID is discussed as if it exists inside a vacuum, free of influence from or consequence to society. In the little time I have, I am going to address a couple of persistent myths that constantly derail and impede rather than build understanding. Myth 1. The claim is that people oppose expanding MAID because they believe mental illness is less real than physical illness and they treat it as less significant and less worthy of support. This claim is false. The division between physical and mental illness is asserted and maintained by the medical model and the Canadian state. A two-tier healthcare system has been built around mental health due to the exclusion of many essential elements from Canada's public healthcare system. The average provincial and territorial mental health care funding lags behind that of many peer countries. Proportionally, Canada's public spending on mental illness is lower than its occurrence among all illnesses. People with mental illness face particular threats to their civil rights and higher levels of police interactions and incarceration. Stigma requires power. Without power, stigma is just someone's bad opinion. When it comes to claims asserted by the myth, the call is coming from inside your house, not ours. As disabled people, we understand disability as one large tent. The experience of oppression is not the same, but the cause of it is. And please remember that the majority of disabled people have more than one disability, and co-occurrence of chronic illness and mental illness is common. Myth 2. Failing to expand MAID is discrimination. This claim is also false. This and other assertions made by proponents of MAID reflect a profound lack of understanding of disability, disability rights, history, and the causes, consequences, and solutions to the discrimination and injustice disabled people experience. Those eager to offer aid in accessing deaf to an autonomy-deprived population are certainly making a choice, but why? At least one study has found that support for euthanasia on the basis of mental illness was positively correlated with holding attitudes of stigma towards people with mental illness. Further, a forthcoming chapter by Trudeau Lemons and Scott Kim demonstrates parity arguments logically lead to absolute autonomy, death on demand for anyone. This aligns with disability analysis that for years has asked, why us? The co-opting, or at best outdated and incorrect, understanding of disability rights invoked in the name of expanding MAID is evidence of the absence of disabled knowledge and understanding. MAID is, among many things, authored by epistemic injustice and must be repealed, not expanded. Thank you.
Dr. Frazee, I understand you have a video, so we'll go to your video. And Dr. Frazee's made a video because of her trouble in communicating.
By acknowledging both the nature and the limits of what I bring today. I speak as someone who has moved through the world for 7 decades with significant physical disability. I've spent a career analyzing that experience within the frameworks of law and policy and culture. I want to underscore that your work on this committee must be grounded in the authority of what the law calls mental illness, authority earned through neurodivergence, psychiatric survival, intersectional identity, and mad scholarship. Seek out persons who have not only lived these realities, but worked them into deep understanding. That's a different undertaking from finding individuals who will speak about their own desire for MAID. First-person accounts have a place here, but they are not a substitute for epistemic authority, and this committee must be clear about the difference. limits. Between 2021 and 2023, I was part of a working group on the MAID practitioner training curriculum. My full account is published this month in the Canadian Journal of Disability Studies, and it's appended to my written testimony. What I encountered there was a culture immune to the self-reflection and humility that ought to attend any decision to authorize death. My questions about whether a MAID applicant's despair arose from a life without validation or support were rejected as threats to autonomy. Vulnerability was narrowed to irrelevance. What remained in the curriculum trains assessors to, yes, verify capacity and consent, but look no further, as if the law's demand for conscientious scrutiny had never existed. In Carter v. Canada, Justice Smith staked this regime's legitimacy on trust in medical judgment, on physicians applying, in her words, the very highest level of scrutiny, the safety of their practice contingent upon the skills and commitment of the physicians responsible. I have watched that commitment up close in a curriculum designed to make practitioners look away. The trust that the court and parliament placed in medical judgment has not been honored. On that evidence, this committee cannot responsibly contemplate expansion of a regime that has not learned to be accountable for the power it already wields. Thank you.
Thank you. Dr. Michelle Hewitt for 5 minutes, and we'll try to hold you to 5 minutes.
Thank you. My name is Michelle Hewitt, and I'm the Chair of Disability Without Poverty. As the Chair of DWP, I want you to know that research from UBC will tell you that 75% of the people living in Vancouver's downtown east side have mental illness. These people don't want MAID. They want supports to live their lives in dignity and to be able to thrive. But today I want to tell you about my husband, Victor Enns, who used MAID to die on December the 9th, 2025. Victor did not want to die. Victor was a poet and a writer, and along with listening to music, he enjoyed life. He had a wicked sense of humor, and he cared for everything that was going on in the world, and he had a deep love for his family. Victor was diagnosed with chronic depression in his 20s, and he was 70 when he died. Around 30 years ago, he got good support from psychiatrists and found a cocktail of drugs that managed his depression well. If MAID for mental illness has existed earlier, Victor might have accessed it during a prior depressive episode. Instead, with more time and good care, his depression was under control. The most disabling part of Victor's life was chronic pain from severe osteoarthritis, but he had good control with an opioid. In 2022, he lost his family doctor. This precipitated a series of events that led to him losing access to that opioid, being prescribed too much of something else, which led to respiratory depression, hypoxia, and a week in a medical coma. After that, he was prescribed Suboxone. Victor wanted his original opioid back as it worked better, but ironically, he was told he couldn't have it in case he had another respiratory depression and died. Early in 2025, Victor requested psychological testing as he felt something wasn't right. The testing said that he had some cognitive changes, but there was no way of knowing how much the drugs that he took for his pain control or the events surrounding his week in a coma played into this. He was diagnosed with early dementia. Victor then started to comment that he thought MAID would be in his future. The possibility of dementia scared him. He was also rapidly reaching the limit that he would be prescribed Suboxone. In May 2025, Victor submitted the paperwork, still thinking of it as something for the future. When we got a date for the assessment, Victor prepared by writing a list of reasons why he thought he should qualify. Within 10 minutes of arriving, including introductions and explanations of what MAID is, Victor was told that the assessor had already decided he had qualified and that he could have either track 1 or track 2. But as Victor had no intention of using it in the short term, he'd put track 2. Within 25 minutes, the assessor was gone. The second assessor arrived telling us he agreed with his colleague. The whole time was spent filling in paperwork. He also said that he'd be happy to assess Victor as track 1 or track 2, and he'd follow his colleague's recommendation for track 2. He left after 30 minutes, telling us when his holidays were so that Victor could plan his death around them. Victor was no more likely to die in the foreseeable future than I am from my MS. There was never any attempt, as designated in the legislation, to try and see if other options would help him. They never saw us again until his life ended through MAID. From that time onwards, Victor's mental illness worsened as his paranoia increased, his pain increased, and he reached the limit of the Suboxone. The sum total, with no support, no pain control, he chose MAID. Do not believe that MAID provides choice and dignity in death. We were told that we could only have Victor die before the provider started his working day or at the end of it. So we chose 4 p.m. only because it was easier than 8 a.m. We had said that Victor could only spend a small time lying on a bed because it caused him so much pain. He'd not slept in a bed for 2 years. That was ignored as he was told to get on the bed far too early. The late arrival of the doctor, lying in a bed and no painkillers because we didn't think he'd need another dose, but everything was running so late, led to him screaming for them to kill him. The IV was poorly placed, meaning they had to switch arms, and I could not be at his side as he died. We were shouting at each other across the room to say goodbye. I don't think Victor's experience is an outlier. The current MAID program is severely broken and it doesn't do what you think it does. Victor was not in control. The only thing he is dead, and he didn't want to die. He felt he had no other option. The current program clearly has such major issues that you should not consider an expansion, particularly for something as controversial as mental illness as the sole condition. Track 1 needs some careful attention, and track 2 needs shutting down. I've come here today to share the most painful aspects of my husband's death, which is not easy to do. So please ask me questions. Thank you.
Thank you, Dr. Hewitt. Ms. Carr for 5 minutes.
Chair and members of the committee, my name is Krista Carr, CEO of Inclusion Canada. We are the national federation representing people with an intellectual disability and their families, 13 provincial and territorial member associations, and more than 300 local associations across the country. Every day, we advocate, educate, and deliver programs in the area of disability and human rights. We work to ensure people with an intellectual disability have the same access, dignity, opportunity, and equality as everyone else. We also live the harsh reality of legislated poverty and failed support systems, housing shortages, inadequate home care, and insufficient disability and mental health supports. We confront systemic discrimination and historical disadvantage. We watch as people are made vulnerable by the very systems that are supposed to be providing support. We navigate systems that regularly send messages to persons with disabilities that they are broken, that they are a burden to their families and to society, and since 2021, because of Track 2 MAID, that their lives are not worth living. We live the consequences of this MAID regime every single day. We see a pattern in which individuals choose assisted suicide, not out of a genuine desire to die, but because the supports needed to live with dignity are simply not made available. We answer calls weekly from individuals with a disability who are offered MAID when they attempted to access the healthcare system for everything from a bruised hip to pneumonia. Across this country, persons with disabilities are being steered toward death when what they seek is help. This is the human side of MAID, and it is not rare. When I tell you this is happening, I ask you to believe me and to believe them. Please do not dismiss these experiences as anecdotes. They are people whose lives are directly affected by the laws you have written. MAID is a human rights issue, and it's an equality issue. Track 2 MAID applies only to persons with disabilities who are not dying. This disability-based access to assisted death constitutes discrimination contrary to Section 15 of the Charter. It devalues the lives of persons with disabilities, reinforces harmful stereotypes, and deepens historical disadvantage. And no amount of additional safeguards can change that. Canadians without disability who experience poverty, isolation, or social suffering are not offered death. They are offered suicide prevention, treatment, housing, and support. Persons with disabilities are entitled to the same response. Instead, however, we are offering people with disabilities MAID instead of help. Track 2 is incompatible with Canada's domestic and international human rights obligations. In 2025, the UN Committee on the Rights of Persons with Disabilities expressed extreme concern about Track 2 and recommended that Canada repeal it, including the planned expansion to mental illness as the sole underlying condition. The committee linked MAID requests to failures in poverty reduction, healthcare, housing, and community mental health services. I will briefly address arguments this AMAD committee has heard. That the disability organizations do not represent the disability community on this issue. This claim is inaccurate and deeply offensive. Disability organizations are governed by and accountable to persons with disabilities. Our organizations are recognized by Canadian courts and international bodies as representative organizations of persons with disabilities. We speak as voices shaped by lived experience and a history of discrimination. You have been asked to give equal weight to end-of-life advocacy organizations. Respectfully, they don't represent people with disabilities as a class. On matters of disability law, Parliament must give greatest weight to organizations rooted in the disability community itself. Parliament is now being asked to add mental illness to Track 2. There is no professional consensus for this. In 2022, the heads of psychiatry at all 17 Canadian medical schools called for the delay, warning there is no accepted way to distinguish a MAID request from suicidal ideation. The American Psychiatric Association opposes physician-assisted death where mental illness is the sole condition. Treat people with disabilities the same. If others in crisis are met with suicide prevention, meet people with disabilities with suicide prevention. If other Canadians with mental illness are met with treatment, meet people with disabilities with treatment. If people with disabilities are poor and isolated, meet that poverty and isolation with housing, income, and support so they can live with dignity. You cannot call it equality when everyone else receives help and people with disabilities receive death. Committee members, maintain the exclusion for mental illness, repeal Track 2, do not write one law for everyone else and another one for us. You cannot reverse death. Thank you.
Thank you. Mr. Patzer, for 4 minutes and 40 seconds, I would suggest, I think that we're all eager to try to get out here by 9:45. So if you want, you're certainly welcome to make it less than 4 minutes and 50 seconds.
That's a tough ask of a politician there, Mr. Chair. But any which way, thank you to all the witnesses for coming today. I really appreciate the stories that you are all willing to share. I'm going to start with Mrs. Carr here. Before this committee even considers expanding MAID to mental illness alone in 2027, can you give us a flavor of the kinds of calls that Inclusion Canada receives from people and families about the existing MAID framework and what these stories tell us about the risks of expanding it further?
Yes, thank you for the question. So we receive calls weekly, and we get them not just from people with an intellectual disability and families, but because we have been vocal on the issue, we get them from all people with different types of disabilities. And they fall into two categories. People with disabilities who reach out to us as a last-ditch attempt to find someone to help them because they have tried so hard for so long to get the help that they need. And people with disabilities who have accessed our healthcare system for just regular, ordinary, everyday things and got offered MAID along the way. Everything, as I mentioned, from a bruised hip because of a fall out of a taxi cab to accessing treatment for pneumonia. One thing they have in common is that none of them have wanted to die. We have had people call us a person with a disability who is a victim of intimate partner violence and had no access to income to be able to get out of that situation, and had, because she was on disability income supports and was feeling like if she couldn't get out of that situation, it would be better to be dead or she may be killed. We've had a person with muscular dystrophy who was living with a parent. That parent died of cancer and was providing a significant amount of support. Once that support was gone, they could not get the support they needed to live in their own home and were going to be institutionalized. We've had people on waiting lists for 3 years for chronic pain management specialists, and the list goes on and on and on. We have a binder of examples.
Thank you for that. And the question before this committee again about, with MAID being the sole underlying mental illness, based on the data we already have, what does it tell us about who is receiving MAID now? Why are they receiving it, and why that should make Parliament cautious about expanding MAID for mental illness?
Well, the data that we have on Track 2 MAID, and often we're quoting the Track 1 data, the data we have on Track 2 MAID tells us that the people accessing Track 2 MAID are disproportionately women, Indigenous, living in poverty, low income, are isolated and feel they're a burden on their families.
Chair, how much time?
40 seconds.
All right, so we're being told this next expansion can be made safe, but if we expand MAID for mental illness as a sole underlying condition, what conditions would that actually include, and what would that mean for suicide prevention in Canada?
So the definition that will be used comes out of the DSM-5, which is the definition of mental disorder in the DSM-5. There are 290 some different labels that fall under that distinction, and that includes intellectual disability, autism, trauma, eating disorders, gender dysphoria, and the list goes on and on and on. So we're talking about a hugely wide expansion to a significant number of people.
Okay, thank you very much, Chair. I will leave my time at that.
Thank you very much. Dr. Ramsey for 4 minutes and 50 seconds.
Thank you. Merci beaucoup à tous nos panélistes.
Thank you to all our panelists, but perhaps I have a question for Ms. Carr to begin with. Ms. Carr, you introduced the notion of social determinants, poverty, lack of housing, isolation. Nobody in this life doesn't have some kind of condition. We don't live in a vacuum. We often have a condition that's associated with other factors, other determinants. I completely share your view that those determinants should be analyzed or certainly discussed with the person. But however, what bothers me, if we deny that person the right to have access to MAID because of determinants like that, we are doing reverse discrimination. Namely, I could say, well, you're poor, so you're not entitled to MAID. Could you comment on that? And my second point is social determinants. How are social determinants affecting mental illness more than physical illness? I would submit that it might be more the case for a physical condition than for a mental condition, but I'd like to hear your views on that.
Much for the question. So, to your first point around the social determinants of health, we have to, yes, you're correct. That applies equally to everybody in the population. Much like Track 1 MAID applies equally. If you have a terminal illness, it doesn't matter what your socioeconomic conditions are or your disability supports or any kind of supports or anything you have in your life, you qualify for Track 1 MAID. Track 2 MAID is a completely different story. We have singled out one group of charter-protected individuals, persons with disabilities. That is the definition that is met under Track 2 MAID. If you have a disability and you are not dying. So there's a fundamental equality issue at play here because we only offer Track 2 MAID to one particular group of people. And the people that we are offering it to, persons with disabilities, tend to have multiple forms of intersecting discrimination, like poverty, like a lack of access to supports, et cetera, et cetera, et cetera. When someone in the general population, suffering is inherent in any, it's equal across the board. Anyone can suffer intolerably. It's part of the human condition. When someone else is suffering intolerably, we do what we can to alleviate that suffering or to provide the supports and services necessary. That's not the case when it comes to people under Track 2 MAID who are accessing those, are under those same conditions. And your second question on whether or not the social determinants of health apply less to people with mental illness than they apply to people with a physical disability, I believe.
Oh, at least no further.
Right. What I would say to that is if people with mental illness are in the situation, they are not dying. They're persons with a type of disability. They are not dying, and they often do not have access to the supports that they require as far as mental health goes. I look at the population I serve. I serve people with an intellectual disability, 40% of whom have a co-occurring mental health issue, mental illness, etc. That they can't even access, even if they could access specialist services, very often those specialists are not trained to deal with people who have intellectual disability or autism and a mental illness. So they're not getting the support and treatment that they require to live a good life. So I would say that it applies the social determinants, and if you layer on the situation that they're in, poverty, when you can't pay for mental health services, when you can't pay for counseling, when you can't pay for psychiatry that isn't provided through your healthcare system, then you are multiply disadvantaged. So I would actually say that the social determinants apply just as much, if not more, to people with mental illness than they do people with a physical disability.
Thank you very much. Mr. Thériault pour 5 minutes.
Mr. Thériault, 5 minutes. 4 minutes. I'd like to thank all the witnesses for their testimony here today. Ms. Carr, if I understand your presentation correctly and your reasoning, you're saying there's systemic discrimination. People with a handicap or disability are ill-treated, and there's a perverse effect in this, which means that a system that cannot properly treat people with a disability would lead them to a single solution, which is medical assistance in dying. Or you're saying that Track 2, because if I understand correctly, you're against expansion of MAID for people whose death is not imminent. So all the cases in Track 2, don't you think that it's discriminatory in a systemic way if, for example, the Supreme Court had said in a general way, any person who has a disability will never have access because they are part of that category of the disabled, and they will never be able to access MAID.
Would say, thank you very much for the question, Mr. Theriault. What I would say to that is the Supreme Court didn't say that. As a matter of fact, the Supreme Court didn't even say that it would apply to people with mental illness. The Supreme Court ruled on the facts of the case before it and was very clear about that.
Excusez-moi.
I'm sorry. The Supreme Court did say that a general exclusion would be contrary to individual evaluation because you belong to a certain category of people, it cannot be said that that category permits exclusion from MAID. So it has to done on a case-by-case basis. If we say you will not have access to MAID because you are a person with a disability, you're engaging in systemic discrimination. Maybe you won't agree with me on that, but that's what I'm hearing you say. You're saying MAID should not be a solution. Well, indeed, it's not a solution. We have to be able to treat people properly, and that's an absolute right. But Ms. Gladu, when she went to the Superior Court, what she said was, I want to be able to have that option, that choice. She was disabled. She lived a full life, but she wanted that option in her back pocket and have access to MAID. If that had been forbidden from her, that would have been systemic discrimination.
I do not agree with you. And what I would say is the systemic discrimination, if that was going to be the argument, then we would offer MAID to anybody who was suffering and wasn't dying. But we don't do that. We offer MAID to people with terminal illness, equally across the board, who are dying. But Track 2 MAID is only for one particular group of people. It's people with disabilities who are not dying. So if we were going to say that this is, we are somehow creating systemic discrimination by why wouldn't we be offering MAID to everybody? We would be offering it to everybody who wanted it, who said they were suffering intolerably. But we don't. We don't do that. And I don't think anybody around this table would think that's a good idea. So why then is it okay to offer MAID to people with disabilities who are not dying? Because their lives are somehow less worth living than everyone else's?
Merci beaucoup, Mr. Theriault. Senator Delphine for 3 minutes.
Merci, Monsieur le Président.
Thank you, Mr. Chairman.
My question will be for Mrs. Carr. You said that your organization receives calls on every day. How many of these people that were offered, you said MAID, how many were assessed? Of these people that you say they were offered, but how many were assessed?
So on the people who have been offered MAID, because to my point, I was talking about people who go to the healthcare system for other typical things anybody else would go for, and they have been asked, have they considered MAID? Are they interested in MAID? Perhaps they should go down this route. And as it was mentioned on the panel...
So, sorry, because my 3 minutes are running fast. So I understand from your beginning of an answer is that they will call you, but you don't know what's happening after. You don't know if they went to the assessment. You don't know if they went to the assessment.
No,
they were assessed like, yes, you can have it.
Those calls, those particular calls that I was referring to are people who have been offered MAID, persons with disabilities not dying, in discussions with a doctor when they were not asking for it and when they were not there for
they called
that
you
reason.
to know what to do.
And when they call us, it's because they are fundamentally traumatized and wounded by the experience.
Understand. I appreciate the comfort you provide. So you have 300 associations, local associations. How many members do you have across Canada, or how many people are within this organization?
So individual members, it's over 40,000.
And about these 40,000 members, how many are, they're all opposed to MAID, and they're all opposed to Mrs. Gladue, what she did, and what Monsieur Truchon did? They all think that they were the two, that these two people were wrong, and everybody else feels that MAID should not be accessible by Track 2?
What they feel is that, and these are the individuals we work with on a daily basis, and our local and provincial organizations work with on a daily basis. And what they feel is that the availability of Track 2 MAID and the further expansion of it embeds stereotypes and discriminatory about their lives and their lives not being worth living and not being worth saving.
So, sorry to interrupt again, but I understand from your answer that all you members are not opposed to Track 2.
No. What we're saying is, yes, our organization and its members are opposed to Track 2. That is what I am saying. And further expansion of Track 2, as is the United Nations.
Thank you.
Thank you, Senator. And sorry, it's 2 minutes and 50 seconds, Senator.
Isn't this 3 minutes? Oh, I see. Okay. I've already wasted a few seconds. Oh, my goodness. Okay. My question, potentially questions, will be for Ms. Gabrielle Peters or Dr. Frazee, maybe one to each. So maybe I'll start with Ms. Peters. Some witnesses speak about the expansion of MAID for people suffering from mental illness as a sole underlying condition as a natural next step to respecting rights. So from the disability community's perspective, does this feel like equality? I know that Ms. Carr has talked about the concerns about expansion, but that is one of the, the positions that we have heard is that it's about equality and respecting rights of individuals. So that mental illness that expansion is important. What are your thoughts on that?
Well, in listening to this last conversation and in general with the committee, it's very clear that there's very fundamental lack of understanding of what disability is, first of all, but also it is not, you can't equate someone's personal opinion in any moment with disability analysis. Okay? Disability rights has evolved from a period of time where people were largely institutionalized and the focus was on independence and the right to live independently. Then we entered the universities, we entered the community, and the analysis has evolved. It's an actual area of scholarship and study. So somebody like Nicole Gladue just saying, oh, I want this. You're equating that with actual analysis of how, given the history, looking at our situation, looking at our lives, and understanding all of these things in context, making a judgment of how this will impact our community. These are not the same discussions that we're having. So I think that absolutely it is not adding to disability rights. And one of the things that needs to be understood is that disability justice, a McGill law professor has written very well and eloquently about the fact of this evolution from disability rights to disability justice. And one of the things he observes is that we kind of went in thinking that if we just, fight for inclusion and integration into the existing systems, that would lead somewhere. But that people consistently come back saying policymakers are not getting it, and they're still not getting that they're not getting it.
Thank you, Ms. Peters. We've run out of time. Senator Lafreda for 3 minutes.
Mr. Chair. So my question is for Ms. Carr. a central concern here that I'm hearing this evening in this debate is the protection of vulnerable individuals. And I take from your view that the current safeguards are not sufficient to identify and protect individuals who may be experiencing the structural vulnerability or external pressures. Would you see any specific safeguards that can correct those issues that are missing, and maybe support, and what level of support do you have for additional requirements such as mandatory multidisciplinary assessment or enhanced oversight in these complex cases?
Thank you very much, Senator, for the question. The first thing I would say is that the current safeguards are flimsy at best and have gaping holes in them. But I would also go on to say, as many others have testified in front of this committee, that when you have a fundamental equality issue, there is no safeguard that's going to fix that. What we have here is a situation where we have singled out one group of people for death instead of support. And 100% of the people that have called and are calling our office are saying they do not want to die. So we have a fundamental disability rights equality problem, and there's no more Band-Aids that we're going to be able to put on that's going to change it. And I would also say that with the safeguards, and I'm using that in air quotes because they, as I mentioned, are flimsy at best, that we do have, there's no oversight to even make sure that they're followed. And we see you just have to look at the Death Review Committee in Ontario and just what they're finding to see that there's really no oversight on whatever safeguards might be in place to start with.
Thank you. Thank you, Mr. Chair.
Thank you. Senator Wallin for 2 minutes, 50 seconds.
Thank you very much. I am sorry to hear the stories that we hear from people on this committee. I happen to have experienced in my own life, and I know many of my colleagues have, they have known close friends or family that have chosen MAID willingly. It was not something forced upon them. It was not something that they chose because they had some kind of disability, either mental or physical, or because of social determinants. This is available under the law, and they have chosen it. So while I think we all agree on one issue, is that discrimination is not a good thing in any way, what I'm hearing from many of you here tonight is that your choices or your situations mean that you are willing to see those who want access to MAID discriminated against. Unless, and I'll start with Ms. Carr, are you in favor of medical assistance in dying in any situation at all?
So first of all, I think we've made our position, thank you very much for the question, Senator. I think we've made our position really clear that we are talking about Track 2 MAID, not Track 1 MAID.
No, but that's why I'm asking about what is your general view of this? Because it influences this other side of people who are not being discriminated against, but who want to access something that is legally available under the law.
It is legally available under the law only to one particular group of people who are not at end of life, who are not dying. And so we are not offering this choice to people who are not dying equally across the board to anyone. We've singled out one group of people who we have decided, because of our fear of disability or because how we perceive that who don't have lives worth living. And part of the reason why people experience the difficulty they experience is because of the chronic ableism and lack of supports.
But many people who have lives worth living but who are ill or through some physical condition, physical illness, it might be cancer, or perhaps they've had mental illness most of their life, but they have come to the conclusion that this is not a quality of life. They want dignity in the way that they live and end their life. Should they be allowed that?
Briefly, Ms. Carr.
So people with people who have terminal cancer, to your point, under Track 1 are already, they have that right to access that. We're talking about expanding this law to first of all, the people that already qualify under Track 1 or Track 2, and expanding it even further to a whole nother group of people who are even more vulnerable based on the fact that mental illness is predicated on a lot of suicidal ideation. And what we are saying is no, that we talk about it this
Thank you, Ms. Carr.
Thank you.
Ms. Jensen for 2 minutes and 50 seconds.
Miss Hewitt, I live about an hour outside of Vancouver, and every time I drive down East Hastings, I see hundreds of poor souls living in squalor, danger, and deep pain. Now, you said that UBC did a study of the population there and found that 75% are living with mental illness, that they want support, not death. So what are we doing if we expand MAID in that reality? Are we treating suffering, or are we giving up on the sufferer?
I think we're giving up on the sufferer. I think that we had previous people that talked about the social determinants of health. If we have not put in place everything that we can possibly do as a society to build people up to where they want to live, so that they want to move beyond surviving and they want to move to thriving, well, then we haven't done our job as a society, and offering them MAID is the easiest way out, because it doesn't cost us any money and we don't have to do anything extra. I find that absolutely appalling. If Victor was here now, he would tell you that his assessment for MAID was the easiest medical assessment he's been through in his life, and it should not be like that. Does that answer your question? I'm sorry.
Yes.
Thank you for the question. Yeah.
Yes, you said there was no real attempt to explore alternatives that might have helped Victor live. Now, if those safeguards are already failing in today's system, why should anyone believe that they're going to work in far more complex cases where mental illness alone is the reason for the MAID request?
Right. As I said, many of us with disabilities, we don't exist, in a single state of disability. And my husband had chronic depression, and in his 20s and 30s, it was particularly unstable. But ultimately, it got under control. So we didn't meet until after that. If MAID had been around then, I would never have met and married my husband. So, I think that the safeguards that are currently in place are insufficient, because I went through a process where I thought I understood what a Track 1 MAID patient looked like and a Track 2 MAID patient, and my husband's died, and I still don't know whether it was under Track 1 or Track 2.
Thank you.
And
thank you, Ms. Hewitt. And I have to apologize for Senator Wells. I forgot him. So you have your 2 minutes and 50 seconds.
Great. Thank you, Chair. My question's for Ms. Carr. Thank you for the concerns you've raised today about people feeling driven towards MAID because of poverty and inadequate supports. Would you agree that the core issue is not MAID itself, but the failure of social systems, and that the solution should be to strengthen those supports while still preserving MAID as an option for competent adults experiencing intolerable suffering?
No, and that is not what we are doing. We are offering MAID to people with disabilities who are not at end of life, and that is the only group that is being offered Track 2 MAID, and now we're going to expand that, or we're looking at expanding that to 297 more labels under the definition of mental disorder in the DSM-5.
So it sounds like, would restricting MAID then in these cases remove a legitimate choice from individuals who are not being driven by poverty, but are making a considered and autonomous decision?
So I guess my question, Senator, back to you would be, why then are we not offering, if that is the premise, we're taking this particular special right away from this particular group of people? If we were worried about that, we would be offering MAID to people not at end of life across the board. It wouldn't be designated to a particular group of people and then further expanded to people with MAID for mental illness. We would be saying anybody who suffers intolerably and is not at end of life has access to MAID and can go to their family doctor or an assessor or a medical practitioner and request it. And that is not what we are saying.
Well, with respect, that's not what we're studying right now. I can appreciate the concerns. Do I have time?
35 seconds.
Okay, if I could move to, I'll pass. I think I have the second round question. Thank you. I'll cede my time.
Okay, thank you. Ms. Tessa Dirksen for 3 minutes.
Thanks very much, Mr. Chair, and thanks so much to our witnesses who are providing testimony tonight, particularly those who are bringing us the lived experiences. Those are really important. We appreciate you sharing that. I'm going to ask a question, what I hope is a practical question, because I think it's important that we get this on the record with respect to provincial healthcare system readiness. And perhaps I'll address to Dr. Frazee first. A decision to expand MAID to those with mental illness was delayed to give provinces and territories time to analyze their capacity to assess and administer MAID for mental illness safely and in accordance with the law. That's really the core scope of this sitting of our special committee. So I'd like you to comment on your understanding of the current state of readiness of the provinces and territories to do this work.
Thank you for the question. The best way for me to respond is from my direct experience and observations working on the curriculum for which MAID practitioners, by which MAID practitioners receive their instruction. And my work on that group, when you read my testimony and my article, is that the profession, the medical profession, has not risen to the gravity of the decisions that we have entrusted them with, and they are unable or unwilling to disentangle those structural forces. I believe you're referring to them as social determinants of health. They're unable to disentangle that kind of suffering in cases involving stable physical disability. I therefore conclude that there is no basis to be confident that they will do so when mental illness is the sole underlying condition. In other words, if they cannot or will not apply the very highest level of scrutiny to these assessments and the moral seriousness that these decisions require, they can't be entrusted with greater power, greater authority over the lives of people who are very vulnerable to harm.
Thank you, Ms. Dr. Fries. Mr. Thériault pour 1 minute 50 secondes.
Mr. Thériault, 1 minute 50 seconds. 1 minute 50. Well, Mr. Chairman, I wanted to put a question to Ms. Frazee, Professor Frazee. In the expert report, there are concerns, and there are a number of precautionary principles in there. When it comes to systemic inequality, it says during the evaluation of a MAID request, independently of the diagnosis of the requester, a clinician must examine whether the circumstances of that person result from systemic inequality. And in recommendation 6, it says that we must ensure that all requesters have access to all the social support that could potentially reduce suffering. We're talking about Safeguard 241.2. The person has to be informed of means available to relieve suffering, especially when that's indicated, so that we can intervene on structural inequality. Those parameters are not sufficient for you if they were applied properly?
No, with respect, they are not. Thank you for the question. Perhaps I can best answer with reference to just one case among many that I speak of in my paper, and that is a case of a young man in his 20s who wanted MAID because he was desperately lonely and felt that he would never find a loving relationship and have what he considered a normal family. I would suggest to you that the roots of this problem, the roots of the suffering that MAID is being deployed to address, those roots are very deep. How on earth can we safeguard against heartbreak, which was what motivated this man to request MAID? And he did die by track to MAID, frankly, of a broken heart and desperate loneliness. We can't safeguard against that.
Thank you, Professor Freese. Senator Wallen for 1 minute, 50 seconds.
Thank you. I guess I just feel that we should put on the record here tonight some balance. We are in the process of declaring an entire profession, doctors, MAID providers, mental health professionals, incapable of understanding matters of life and death, and that this entire group of people is inclined to break the law and risk their licenses from some desire to provide MAID to people who don't want it. And I guess I'll ask Dr. Freese that question. Are there no other kinds of doctors in Canada?
Well, number one, they're not breaking the law. That's the problem. They're interpreting the law liberally. They have.
Well, certainly they would be breaking the law if they were providing MAID to those with mental illness as a sole underlying cause, which many of you seem to be suggesting.
I'm not sure. I'm not sure any of us did suggest that. What I'm suggesting is that they are not, they're in a position where much of the suffering that their patients are speaking of is not medical in nature. And yet, under the MAID regime, as long as there is a significant physical disability to which this suffering can at least in part be attributed, then the requirements for eligibility are met, and it's a legal death. But that isn't surely what this Parliament or the court intended.
Thank you. And last of all, Senator Wells for 1 minute and 50 seconds.
Thank you. Dr. Freese, the committee received a letter from the President of the Medical Regulatory Authority of Canada, signed by the medical regulatory heads from across Canada, all saying that medical regulatory authorities in Canada are ready for the expansion of MAID for persons with a mental illness. So based on what you've shared with us today, what additional evidence should Parliament consider before expanding Track 2 MAID for persons with a mental illness, knowing that the regulatory bodies have clearly said they have a duty to be ready?
I would request that you pay close attention to the evidence and the arguments being advanced right now in the constitutional challenge to Track 2 MAID that I'm sure you're aware of as it works its way through the courts. You have heard and you will hear from many of the organizational plaintiffs representing people with disabilities across the country, and I hope our voices will be heard.
So would you say we should leave this decision up to the courts rather than Parliament?
No, I'm sorry, I didn't mean to imply that. I meant that you will find well-reasoned evidence ready for your review and for you to weigh and to give weight to inappropriate measure and not just what the provinces are saying.
Thank you very much.
Thank you very much. And with that, we conclude the second panel. I'd like to thank all the witnesses for coming today and their very important testimony. We certainly have heard from you. Thank you. We will suspend have Dr. Carrie Frock, Associate Professor, University of New Brunswick, Daphne Gilbert, Full Professor, University of Ottawa, Faculty of Law, Isabel Grant, University Killam Professor, University of British Columbia, who will be sharing her time with Elizabeth Sheehy, Professor Emeritus of Law, University of Ottawa, by video conference. Maybe I'll start with Dr. Frock, followed by Dr. Gilbert, followed by the two on video.
Thank you very much. Good evening. I very much appreciate the invitation to appear.
Say, each of you have 5 minutes. I will try to, with about 30 seconds to go, to try to indicate that fact.
I'm a constitutional law professor at the University of New Brunswick. My teaching and research focus on the Charter, equality rights, and the interaction of equality in Section 7, and I publish extensively in those areas. At the outset, I want to be clear, the Charter does not require extension of MAID to mental illness as a sole underlying condition. Carter does not establish that requirement, and Section 15 does not compel it. I'd like to make 3 points. First is that Carter does not constitutionally require the extension of MAID to mental illness. Second is that any group advancing a Section 15 equality claim must demonstrate that partial decriminalization transforms an exemption from criminal liability into a benefit under federal law. This would be a novel claim with no authoritative precedent. Third, even if that hurdle is overcome, substantive equality under Section 15 does not require full decriminalization. Truchon assumes that equality requires identical treatment as between groups with disabilities. It does not. Turning first to Carter, Carter was a Section 7 decision grounded in causation. The claimants had to show that state action caused the deprivation of life, liberty, or security of the person. The violation of the right to life depended on the Supreme Court's acceptance that the law caused premature death. It accepted that some individuals with grievous and irremediable conditions would take their own lives prematurely for fear that they would be incapable of doing so when their suffering became intolerable. This cruel choice, the court's words, also imposed psychological suffering. At the point of physical incapacity, the prohibition engaged liberty and security of the person because it precluded autonomy over one's life and prolonged suffering. Carter did not mandate extension beyond that defined class. The court accepted that the state has a legitimate objective in protecting vulnerable persons from being induced to commit suicide, and that carefully designed limits are permissible. It says, drawing lines is justifiable through stringent limits that are scrupulously monitored and enforced. Turning to Truchon and Section 15. Now, Truchon is often relied upon to support an equality argument, but the case is less stable doctrinally than is sometimes suggested. Section 15 is engaged when the state provides a benefit or imposes a burden unequally. Parliament is not providing MAID as a benefit. It has created a limited exemption from the criminal law. Characterizing that exemption as a benefit would be a significant and novel extension of Section 15, not supported by existing Supreme Court jurisprudence such as Otten or any other lower court decision. Parliament under the Criminal Code is not providing access to MAID to anyone. Second, even if the benefit framing is accepted, Section 15 prohibits distinctions that are substantively discriminatory, those based on prejudice, stereotyping, or perpetuate disadvantage. Here, the distinction reflects the recognized limits of medical knowledge, the inability to reliably determine irremediability in mental illness, and the difficulty in separating suicidality from MAID requests. Treating those differences as material is not stereotyping or perpetuating disadvantage. Section 15 requires evidence about the claimant group, and differential treatment that corresponds to their circumstances is not discriminatory.
Seconds. Seconds, go on.
Okay. Truchon did not address the benefit problem. And equality is not about the ability to make choices exclusively. It's only when limits on autonomy are linked to stereotyping or perpetuation of disadvantage that they may result in a violation of Section 15. So the current law reflects an attempt to respond to materially different risk profiles in a way that manages the distinct nature of mental illness in the MAID context. So thank you, and I appreciate any questions.
Thank you, Professor Gilbert, for 5 minutes.
Members of the committee, thank you for inviting me to join you this evening. I'm realizing tonight that I'm the odd person out in terms of this gathering. My name is Daphne Gilbert. I am a full professor at the University of Ottawa, Faculty of Law. I have taught constitutional and criminal law for over 25 years and have researched MAID since the Carter decision. I am also Vice Chair of Dying with Dignity Canada, though I appear here in my individual capacity as a law professor. I will focus my remarks solely on MAID, where mental illness is the sole underlying condition, MISUMC, as I understand this committee's mandate to be limited to that issue and not to all of Track 2 MAID. The exclusion of individuals who would otherwise qualify for MAID, but for the fact that their grievous and irremediable condition is a mental illness, is discriminatory and violates Section 15 of the Charter, the Equality Guarantee. It has been 6 years since the government accepted that it had to permit people with MISUMC to request MAID, yet it continues to delay implementation. To quote the Supreme Court of Canada in Attorney General versus G, a 2020 decision, quote, people with mental illnesses face persistent stigma and prejudicial treatment in Canadian society, which has imposed profound and widespread social, political, and legal disadvantage on them, end quote. This exclusion adds medical disadvantage to that list. Consider the classic image of an iceberg. The small visible tip above water represents the very limited number of individuals who would ultimately qualify for MAID MISUMC. Clinicians agree that only a small number of people will ever meet the stringent eligibility criteria and rigorous safeguards. This matters because one justification for continued exclusion is the speculative claim that large numbers of people will become eligible if the ban is lifted. There's no evidence to support that claim. The much larger mass of ice beneath the surface represents the thousands of individuals harmed by the language and rationale of exclusion. They are harmed by the suggestion that because of mental illness, they lack decision-making capacity, must be protected from themselves, and that their suffering is somehow less real or less serious than physical illness. In 2026, we are reinforcing historic stigma and paternalistic assumptions, attitudes we claim to reject. Public campaigns like Bell's Let's Talk Days encourage honest conversations about mental health, but the law continues to infantilize those with mental illness. Our commitment to equality is measured not by empty messaging, but by equal legal treatment. As affirmed in 2026 by the Supreme Court of Canada, the Section 15 analysis has 2 steps. First, does the law create a distinction based on an enumerated or analogous ground? Here it clearly does. The exclusion differentiates on the basis of disability by treating those with mental illness differently from those with physical conditions. Second, does the law impose a burden in a way that reinforces, perpetuates, or exacerbates disadvantage? Again, the answer is yes. The law denies access to MAID, and in doing so, reinforces stigma and harmful stereotypes that individuals with mental illness are incapable and in need of protection from themselves. These messages affect not only the small number who might qualify, but the broader community who hear them echoed in legal and policy settings like these committee sessions. This breach of Section 15 cannot be justified under Section 1. The stated objectives, protecting vulnerable individuals and ensuring system readiness, do not support a blanket exclusion. Following repeated extensions, there is no clear benchmark for readiness. A constitutional violation cannot rest on an undefined and shifting standard. In contrast, those working within the MAID system have indicated that they are ready. Nor is the exclusion minimally impairing. A blanket prohibition denies any possibility of individualized assessment, At minimum, there must be a mechanism to allow individuals to be assessed, as discussed in the G case. Finally, the exclusion produces no salutary effects.
30 seconds.
Rather than protecting vulnerable individuals, it deepens stigma and marginalization. I remind this committee that decision-making capacity is at the heart of all MAID requests. To suggest that an entire category of competent adults should be denied a legal medical service is profoundly discriminatory. I look forward to your questions.
Under time. 5 minutes between Professor Sheehy and Grant. I assume between you, you know who's going to start.
Yes, thank you. That's me. Thank you for inviting us to speak to the committee tonight. I'm delivering our remarks, and Professor Grant will answer questions. Professor Grant and I are legal scholars with a combined 75 years of collective experience working on violence against women, and we've published multiple papers on Track 2 MAID. If MAID is extended to those whose sole disabling condition is mental illness, it will disproportionately end the lives of mentally ill women, just as Track 2 already disproportionately ends the lives of disabled women. As scholars who've devoted our lives to ending violence against women, we urge you not to take this discriminatory path. The UN Committee on the Rights of Persons with Disabilities highlighted the ableist assumptions underlying Track 2 and urged its repeal, including the planned extension to mental illness. The committee expressed its concern about the disproportionate number of women accessing Track 2 and the role of gender-based violence in the marginalization of disabled women. It's important to understand that when one allows doctors to provide MAID to people to end difficult lives as opposed to hastening difficult deaths, one inevitably targets the most marginalized Canadians. Health Canada data backs this up. Approximately 59% of all Track 2 deaths in 2022 and 2023 were women, as were 57% in 2024. Track 2 recipients are younger, more likely to live alone, and more likely to report loneliness, perceived burdensomeness, and a lack of dignity in their lives as reasons for seeking MAID. Ontario data suggests they are more likely to live in the most marginalized neighborhoods and less likely to have family members as next of kin. Professor Grant has demonstrated the discriminatory impact of Track 2 on women, which will only worsen if MAID is extended to mental illness. When we examine the jurisdictions that allow psychiatric euthanasia, we see it's overwhelmingly women who are dying. In one study, researchers found that of 100 patients who applied for psychiatric euthanasia in Belgium, based on at least one psychiatric disorder, 77% were women. Those women were on average just 47 years old. Dr. Marie Nicolini and her colleagues found that between 69 and 77% of those receiving psychiatric euthanasia in countries where it is allowed are women. Research helps explain why this pattern occurs. Dr. Nicolini explains that the gender breakdown for psychiatric euthanasia is virtually identical to the gender breakdown for attempted suicide. The fact that almost twice as many women attempt suicide but more men complete it is because men choose more violent means to end their lives. Most women who attempt to suicide do not go on to die from suicide. But psychiatric euthanasia risks turning the disproportionate numbers of women who attempt suicide into completed suicides by offering a way to die that is portrayed as peaceful and painless. Male violence contributes to women's mental illness through conditions like depression and PTSD, but this violence is also disproportionately targeted at women with mental illness. Stats Canada data indicate that 25.9% of women with mental illness report sexual violence, at least double the rate experienced by other women. People with mental health disabilities also face 3 times the risk of intimate partner violence. Alarmingly, male violence also contributes to suicidality. A recent study published in The Lancet demonstrated that women who've experienced intimate partner violence were 4 times more likely to have attempted suicide than other women. Those who had experienced sexual abuse within a relationship were 7 times more likely to have attempted suicide. Data from the Netherlands and Belgium show that 36% of those who died from psychiatric MAID had a history of trauma, for example, from physical and sexual abuse. We know that it is women who are disproportionately subjected to physical and sexual violence.
30 seconds,
Yet Canada collects no data on the role of trauma in MAID requests. Canada's resources should be focused on providing better supports for women with mental illness to escape male violence and to live dignified lives, not to developing secretive curricula for training people to facilitate their suicides. We urge this committee to take the UN recommendations seriously and have the courage to put an end to the prospect of MAID on the sole basis of mental illness. Canada will never be ready to facilitate the suicides of women with mental illness. Just a reminder, please direct your questions to Professor Grant, who will respond on behalf of both of us. Thank you.
Thank you, Professor Sheehy. First up is Mr. Cooper for 5 minutes, 4 minutes 50 seconds.
Thank you, Mr. Chair. Professor Frock, the only time that the Supreme Court in Carter touched on MAID for psychiatric disorders was in the context of finding that slippery slope concerns and data from other jurisdictions were not relevant because, quote, they would not fall within the parameters suggested in these reasons at paragraph 111, and that they are the product of a very different medico-legal culture, and that these cases offer little insight into how a Canadian regime might operate. Do I have that right?
Well, that's right. Carter was responding to a very particular set of facts before it, and those facts and the evidence included the evidence from other countries that was before it. It was specifically asked and talked about MAID in relation to mental illness at one paragraph, and it said we're not dealing with that case, we're not dealing with that on the facts before us. So that's really the limitations of Carter. Now, Carter also didn't deal with Section 15, which I'm pleased to talk about too, because I don't think equality rights means extending the criminal exemption as well.
Okay, and just to be clear, nowhere in Carter did the court specifically recognize a charter right with respect to MAID in the context of mental illness being the sole underlying condition.
No, and Carter was dealing with a blanket prohibition that existed at the time, and it was asked to evaluate that blanket prohibition in relation to Section 7. And as I mentioned, it was dealing with state action there because the court accepted on the facts that people possibly were terminating their lives prematurely because they may become physically incapacitated. We're not dealing with that here with mental illness.
Now, Professor Downey and others have cited the 2016 EF decision, but in EF, the court, in that case the Alberta Court of Appeal, made no pronouncement on the constitutionality of a legislative response that might exclude MAID for mental illness, correct?
As I understand EF, it was based on asking for an exemption, which was permitted under the Carter decision. And as I understand EF as well, it was in relation to having a psychiatric overlay to a physical condition. So in that respect, it's not a precedent for anything. It was, simply asking for an exemption.
That's right. And the court said expressly in paragraph 24, these are not individual constitutional challenges, that they were dealing with whether the applicant qualified for the constitutional exemption at the time before the passage of Bill C-14. Now, you touched upon Truchon, and just to be clear in that case, the question before Madam Justice Beaudoin was not concerning a condition of a sole underlying mental health disorder, right?
That's right. And the thing about Truchon is in the evidence before that case, it was dealing with people that had grave, irremediable physical conditions, but just couldn't meet the standard of that their death was reasonably foreseeable. Obviously, that doesn't apply in the case of where the sole underlying condition is mental illness.
Right, and a paragraph 386 and 387 of that decision, Madam Justice Beaudoin said, quote, neither Mr. Truchon nor Ms. Gladue has a psychiatric illness that could be related to the request for medical assistance in dying. Therefore, the relevance of any evidence adduced by the Attorney General of Canada on the subject of people who might avail themselves of medical assistance in dying based solely on a psychiatric illness is doubtful, to say the least. In other words, it wasn't relevant to the issue before Madam Justice Beaudoin that she was to determine.
That's right.
And so therefore, to date, no Canadian court has specifically recognized a charter right to MAID where mental illness is a sole underlying condition, right?
Very brief answer.
That's right.
And so why should we presuppose? Okay.
Time's up. Dr. Jensen, Jasek, pardon me, Jasek. I don't even remember your name.
Professor Gilbert, your work has examined MAID through a charter and an access to care lens. This evening we've heard certain concerns that perhaps Track 2 to date has been in some way particularly offered to those with a disability, where perhaps social supports or other interventions could mean that Track 2 was inappropriate. Could you tell us actually what the stats actually show, the data is, because I believe there are annual reports. So could you detail to us, in terms of Track 2, who is actually accessing MAID through Track 2?
So I recommend to the committee that you consider inviting Dr. James Downer and Dr. Kieran Quinn, who published empirical study in the fall of 2025 that looked at all of the data around Track 2 MAID. And with respect to the question around marginalization, by every metric, MAID recipients are less marginalized than the appropriate comparator. And MAID recipients are overrepresented in the highest income quartile relative to the general population of natural deaths. So we understand that most MAID recipients are white, they're educated, and they have means. And as far as the statistics around gender, it is true that there are slightly more women than men who avail themselves of Track 2 MAID, but that tracks with the epidemiology of the populations with chronic conditions. Women are more likely to develop these conditions and less likely to die from them, so it's not a purely gender-driven issue.
Thank you for the clarification. Now, Professor Sheehy has made some comments in relation to international experience. So what would you recommend in terms of potential safeguards should medical assistance in dying be available where the sole underlying condition is a mental illness? What do you see as some of those requirements?
I think the existing safeguards are more than adequate to deal with adding mental illness as a sole underlying condition. I have found it really troubling today to hear MAID providers described as murderers. If there are egregious provisions happening, there should be criminal charges laid. There should be reports to the police. There has never been a criminal prosecution of a MAID provider. And similarly, they could be reported to the appropriate college. And again, we don't know of any disciplinary proceedings that have successfully resulted in any sanction for a MAID provider. So, you know, I think the existing safeguards are very strong. There are multiple criteria that have to be fulfilled, and I think that can accommodate MISUMC.
Thank you.
Thank you. You're going to end it at that. Mr. Thériault pour 4 minutes 50 seconds.
Mr. Thériault, 4 minutes 50 seconds. Thank you. My first question was for Professor Kinder Gilbert. Quebec had legislation even before the Supreme Court made the Carter decision. And because of the Carter decision, Quebec had to amend its initial legislation, which consisted in allowing MAID in cases where people were end stage of life. Because of the Gladue and Truchon decisions and the Baudouin decision, Quebec realized that its legislation excluded a number of people and could be discriminatory, and changed that law recently. In addition, in its end-of-life care legislation, Quebec has a committee that is to correct legislation and put them into question. Every made decision is subject to some questioning thereafter. That doesn't seem to be the case in other parts of Canada. But perhaps that's a solution for people who are worried about how this is carried out. Professor Dany told us when he appeared before the committee that a complete prohibition when it comes to people with mental illness goes against the Carter decision because it does not allow for individual evaluation. I imagine you agree with that.
Okay. Elle a aussi indiqué.
She also indicated that temporary exclusion of access to MAID for mental illness constitutes a violation of the Charter and cannot be justified under Article 1. She referred to Mr. Justice Cheyenne in the Truchon decision. I don't know whether I have to repeat what he said, but the rights that are guaranteed must be based on a legislation that could not be passed in a reasonable time frame. So she pointed out that we're in that situation. There could be an unreasonable delay if we constantly push back the MAID legislation. What do you think of that? Are we respecting Article 1 by pushing this back constantly?
I would note, my recollection of Professor Downey's testimony was that she pointed out to the committee that this has been by far and away the longest extension of a suspended remedy in Charter history, by far. 6 years is an incredibly long period of time to suspend Charter rights. And, you know, I know that the committee is going to hear from CAMAP and FEMRAC on the medical regulatory authorities' oversight on MAID, but it exists and it is robust across the country. And you know, the G decision from 2020, which talked about individualized assessments for MAID for individualized assessments under Section 15, is a really important reminder that, you know, blanket prohibitions don't withstand Charter challenges.
Advenant le cas où le
In the case where the committee can't agree on the interpretation of the Carter decision, we already have two witnesses who have a different interpretation. Do you think it would be important to ask the Supreme Court for an opinion and have it inform us of the interpretation we should have on this topic?
I have no doubt that this issue will make its way to the Supreme Court of Canada. There is a Charter challenge right now in Ontario to the continued exclusion of MISUMC. So, you know, I suspect that we will get the voice of the Supreme Court weighing in on this at some point. It will be an important voice, but I think it can't alleviate this committee or this government's obligation to be respectful of Charter rights and to do what is right for Canadians.
You, Senator Dauphin, for 3 minutes.
Merci, Monsieur le Président.
Thank you, Mr. Chairman.
My questions will be directed to Madame Gilbert. You are part of Dying with Dignity. You're one of the advisors, I think, on legal issues. And in 2024, August, you were quoted in a press release that was announcing the launch before the Ontario Superior Court of Justice of a constitutional challenge. Here we are a year and a half later. So where are we at now in this file? Are we going to proceed soon?
I would love it if someone from the government would let me know. We are expecting the government's response materials at the end of April. So we have filed our claim, we have filed all of our expert opinions, and we're just waiting for the Department of Justice to catch up.
I see. There's a court management, I suppose, for that file?
There is, and yeah, we're hoping in the next week that we'll have those materials.
So is there a date scheduled for the hearing?
No, it's my understanding that Ontario is incredibly backed up in terms of its court dates, and we're not anticipating a date till sometime in 2028.
So I understand that the preferable route will be to go straight to the court of the Supreme Court on a reference case, I suppose.
That would be an option. I'm not sure it's necessary because I think that the government.
There.
Well, eventually, but I also think the government can make a decision to just lift the exclusion in March, and that would be the right thing to do instead of, forcing people to go to court.
Thank you.
Thank you, Senator Martin, for 2 minutes 50 seconds.
Yes, thank you. This question is to Dr. Frock. We've heard deep expert disagreement about irremediability and suicidality in regards to mental illnesses. So if the core criteria themselves are not reliably accessible, is Parliament entitled to keep the exclusion in place under the Charter?
Yes. Essentially, what Section 15 says is that sometimes differential treatment is required for equality. Now, we have various unresolved issues with respect to mental illness, as you've pointed out, and equality doesn't mean that you have to ignore those. So if you as a committee and Parliament decides that mental illness as the sole underlying condition presents special problems of prognosis, irremediability, suicidality, then drawing a distinction on that basis is not necessarily going to be found to be discriminatory by a court. And in fact, as you've heard, there's a competing equality consideration that you've heard from disability rights organizations say that removing criminal protection from this group rests on an ableist principle that their lives are not worth living and that death is a better option for them. And I commend Dr. Isabel Grant's Section 15 article about that very thing. So what I want to emphasize, however, and what my colleague and friend Dr. Gilbert neglected to talk about is the very first thing that you have to prove under a Section 15 analysis is that there's a benefit under law. You don't even get to the equality test, the two-part equality test, unless you can show that. And the variation through the provinces, we have Alberta now passing its own legislation, Quebec has its own legislation. Provinces are the ones that provide MAID. So even accepting that MAID provision is a benefit, this is not under the federal law. The federal law is only granting an exemption to criminalization. So
Thank you.
therefore, Section 15 may not even apply here.
Thank you, Professor. Senator Lafreda for 250.
Thank you, Mr. Chair, and thank you to all our panelists for being here. My question is for Professor Gilbert. Your work has focused extensively on equality rights and removing discriminatory barriers in access to MAID. How do you reconcile the expansion of access based on equality rights with the obligation of the state or the government to protect individuals who may be vulnerable due to mental illness, particularly where capacity and irremediability and external pressures are difficult to assess? And where should Parliament draw the line between expanding the rights and ensuring sufficient safeguards?
So So I would defer to clinicians with respect to how they go about making their assessments in terms of the medical process for that. But the legal safeguards are very strong. They, it's not only that you have the condition. It's not only that you have the mental illness. It has to be a serious mental illness. It has to be, it has to have serious, enduring physical or psychological suffering that is intolerable to them. So the word enduring says to me a length of time, right? A lengthy period of time. You have to be in an advanced state of irreversible decline in capability. So these are all qualifiers to the definition of what a grievous and irremediable condition is. So it's not just that you have the mental illness or a disability, it's that you have all of these other qualifiers that make it a much more serious condition that then I trust our clinicians to be able to assess.
Thank you. Thank you, Mr. Chair.
Thank you, Senator Wallen, for 2 minutes, 50 seconds.
Thank you. Professor Gilbert, you are indeed 1 out of 9 or 10 witnesses tonight on the other side of the issue. The testimony has been quite imbalanced on that score. So I'd like to hear from you as to what you actually think the limits now are on the federal government. You've talked about 6-year delays, that they could simply move to lift this restriction and they would be in compliance with the law. And then the second part of my question is about the provinces and where they stand, because we are told that they have the power to make the rules and access much more restrictive, but they can't make it wider. They can't make something illegal legal. So if you could answer where the feds are and where the provinces are. Thank you.
So I do think that the task for the government is simple, and that is to lift the exclusion. As I said, the government has already accepted that it eventually has to include MIS-UMC. And so, a 6-year delay was unnecessary, but that's what we have, and we shouldn't add to it in any way. As far as the provinces are concerned, the provinces are also required to be charter compliant. So in terms of whatever restrictions provinces put into place with respect to MAID, we'll have to make sure that they come very clearly within the health authority that the provinces have and that they're not a colorable attempt to regulate in criminal law. But there will be charter challenges, I'm sure, in the provinces, which is why it would be preferable, in my opinion, if the federal government had a strong message around where it stands on MIS-UMC.
Would that require a change to the criminal code or a continued exemption from it?
All it would require is to lift the sunset clause, to lift the exemption, and then mental illness would be part of Track 2 with all of the safeguards inherent in Track 2.
And are we going to have to go through this process, do you think, through the courts in 10 provinces and 3 territories?
Well, we certainly have it already happening in Ontario, and I would imagine it will follow suit across the country if we don't lift the extension.
Thank you.
Or exclusion, rather, yeah.
Thank you, Professor Wells, for 2 minutes, 50 seconds.
Thank you. My questions are for Dr. Gilbert. We've heard many references, including again here today, to the UN Special Rapporteur and the 3 UN experts and the UN Committee on the Rights of Persons with Disabilities and the conclusions they have drawn with respect to MAID in Canada. Do you believe it would be reasonable for us as committee members to base any conclusions about MAID, MIS-UMC on these documents?
There's nothing on the record in that report or in the committee reports from the UN that they consulted with anyone outside of those who are opposed to MAID, MIS-UMC. They didn't talk to any experts or people with lived experience who were not opposed. They had a private briefing session with organizations that only brought the anti-Track 2 perspective, and so I think it's hard to base profound decisions like what you're facing on a report that is based on very one-sided submissions, and it would be better to consider the research that is objective and that is based on looking at both sides of the issue.
So it sounds like that's a reminder to our committee to ensure that we are balanced in perspectives over the course of our hearings and that we do not favor any one side over the other. Thank you for that. Is it true that the plaintiffs in Truchon and Gladue were persons with disabilities? For example, were not on what came to be known as Track 1?
Yes.
Is it true that decisionally capable people with disabilities have the legal authority to refuse life-sustaining treatment?
Yes, if they have capacity, then they can make decisions about their treatment.
Is it true that decisionally capable people with disabilities living in circumstances of what some describe as internalized ableism or socioeconomic vulnerability or marginalization have the legal authority to refuse life-sustaining treatment?
As long as all of their options are carefully reviewed with them as required by the legislation, then yes.
Is it true that decisionally capable people with serious mental illness have the legal authority to refuse life-sustaining treatment, even when the consequence of that refusal will be death?
Yes, capable people can choose death.
Is it true that decisionally capable people with serious mental illness living in circumstances of socioeconomic vulnerability and marginalization have the legal authority to refuse life-sustaining treatment?
Yes, as long as their options are carefully reviewed with them as the legislation required, then yes.
Thank
you, Senator. We go to the last round. Ms. Jensen for 2 minutes, 50 seconds.
A woman's assisted suicide request is rooted in violence, trauma, or abandonment, and Canada responds by making her eligible for MAID on the basis of mental illness. Is that really about autonomy, or is that a profound failure of protection? Dr. Grant.
Well, obviously, I think that's a profound failure of the system in a number of ways, not just in terms of protection, but in terms of the fact that we have woefully failed to provide the resources that women need to escape violence. And much of my research has focused on how women with mental illness are particularly targeted for violence and for sexual violence. And the idea that death to the victim would be an appropriate response to violence against women is utterly untenable. And if I could just mention that Professor Sheehy and I participated in the UN hearing. It was open to any organization that wanted to make a submission. So I do take issue with that assertion that they were having secret meetings. Those meetings were open to any organizations that wanted to make a submission.
So Canada doesn't even systematically track trauma, abuse, or violence in MAID requests. So how can Parliament consider expanding MAID for mental illness when they're still blind to some of the very factors that are driving women toward death through MAID?
I mean, I think the work of Dr. Nicolini and Dr. Kim has really demonstrated the degree to which trauma and a history of violence do contribute to a desire to die, either through suicide or through psychiatric euthanasia. So I just don't see a safeguard that's going to prevent that in a world where women are facing
violence. Thank you. I cede my time to Mr. Lawton.
Thank you. Professor Gilbert, you've spoken and have advocated and written that healthcare facilities that are publicly funded should not have the right to not offer MAID on the basis of a religious objection. We have had testimony from numerous psychiatrists, medical practitioners that do not feel for medical reasons, knowledge of psychiatry, that MAID for mental illness should happen at all, irrespective of safeguards. Do you believe healthcare facilities should be allowed, if this expansion proceeds legally, to not offer this to people with mental illness solely based on that?
Very briefly.
I believe that individual practitioners have the right to have a conscientious objection, but not institutions.
So you'd force institutions to euthanize people with mental illness, even if they don't believe it's medically legitimate?
I would say that institutions don't have charter rights.
Thank you. Where am I here? Minutes, 50 seconds. Oh, okay. Sorry, Christina. 2 minutes. 50.
Put it in the chat group. Thanks, Mr. Chair. I want to take us back to the Charter, and particularly with respect to compliance. So this is for Professor Gilbert. And I'm going to rely a little bit on Morgentaler because I think there's some lines to be drawn here. In that case, Justice Wilson stated that she believed the framers of the Constitution were contemplating the freedom of the individual to make their own choices for good or ill, I believe were her words. So this was implying the right to make decisions about one's end of life, including through MAID, as a fundamentally personally autonomous choice. So you mentioned that you believe MAID provisions would be saved by Section 1 of the Charter. is it safe for me to presume that that's based in part on the contention that although consenting to medical treatment is different than consenting to MAID, the same basic conditions apply? And in both situations, a capacity assessment must be completed by a medical practitioner.
Yeah, so, to my mind, first of all, Justice Wilson and Morgentaler spoke really passionately about the fact that people should have the right to make fundamental life choices, which would include the most fundamental, which is when you want to die or how you want to die, if you are eligible for MAID. As far as capacity assessments are concerned, of course, people, can only receive MAID if they are capable of understanding and consenting to MAID. And there are additional safeguards around that in the legislation, that they have to be informed of all of their alternatives. They have to have considered, what else could be done for them. And the practitioner has to be satisfied that they have actually seriously considered those things. That's all in the legislation.
Perfect. Thank you. So just leading off of that, we heard concerns from a previous witness tonight about the importance of requisite capacity in providing consent for medical decisions and particularly in accessing MAID. And she represented folks with intellectual disabilities. And it could be argued that consent is actually impossible in that context because those Canadians lack the intellectual capacity to understand the consequences of those decisions. So can you comment on your understanding of the legal nexus between an intellectual disability and the ability to consent in the MAID context?
So again, I'm not a clinician, so I really can't comment on how capacity assessments are done. That is totally in the purview of medical professionals. And I think that people with intellectual disabilities can sometimes have capacity. It would all depend upon on the assessment of the provider.
Thank you.
That's great. I'll yield the rest of my time.
Monsieur Thériault pour 1 minute 50 seconds.
Mr. Thériault for 1 minute 50 seconds. Thank you, Mr. Chairman. Once again for Professor Gilbert. How can one explain that the history of MAID in Canada always results from the decision of the Supreme Court so that MPs can finally legislate? How do you explain that? How do you explain that?
I appreciate that it's very hard to be in your position, and it's very hard to be in the position of having to legislate around really complicated social issues, and I'm not surprised that so many of these issues, like abortion, like MAID, ended up at the Supreme Court of Canada. I think that it's very hard for you to weigh all of the conflicting constituents that you have with different opinions, and really it is the court's ultimate role to pronounce on charter rights. I think, though, that the government, when it knows what the charter right is and knows what the entitlements are, should act to do that.
Mais n'est-ce pas?
Yes, but isn't it up to the legislator to come up with legislation and do it in accordance with the benefit of the people they represent? And isn't it abnormal that after the Carter decision, we're still having citizens bear the burden when they're suffering in order to get their rights respected? And there's very little time to discuss these things in Parliament. Today we had 6 years by 2027, but isn't it abnormal to leave this burden up to citizens?
I think it's unfair. I think it is very unfair.
Thank you. Senator Delphine for 1 minute 50 seconds.
Yes, thank you. I'm coming back to this pending litigation. Intervenor status, was it granted to some organizations so far?
No, we have not reached the state yet where we are welcoming interveners. And I do want to say one thing about that litigation in terms of the burden that we put on people. We had 2 plaintiffs with lived experience of severe and profound mental illness going over decades. And one of those plaintiffs dropped out because the litigation was just taking too long and the burden on them was too onerous. And that's a very real consequence of litigation. And, had we not continued the extension, then that burden would have been put on those people.
I certainly share that these comments in my dissent in the last report. I made it clear we should refer the matter to the Supreme Court right away, just to end the sufferance and make a clear path for the people to know that they have access to it or not. I thank you for your presence tonight, all the witnesses.
Thank you, Senator. And finally, Senator Martin for 1 minute, 50 seconds.
Okay, very little time, and I guess this is the last question, but I'll direct it to you, Dr. Grant. You said expanding MAID would disproportionately end the lives of women. You can comment on that or anything else you heard that you wish to have the final say.
Thank you. I think we have to be really suspect of any federal law that is disproportionately going to result in dead women. And unless we're going to say that we're totally different from the experience in Europe, or that somehow MAID for mental illness is fundamentally different from what we've already seen with Track 2, we are going to end up with dead women, and dead women with mental illness who have a history of being marginalized and their autonomy being denied precisely by the medical profession. The other thing I just wanted to point out is there's other litigation going on in Ontario that also has individual plaintiffs who have had an enormous burden imposed on them by the existence of MAID. Both of those plaintiffs have mental illness. Both of those plaintiffs were offered MAID when they were what they were seeking was support to live. And both of those complainants have a long history of marginalization by the medical profession. So the idea that offering death is somehow going to promote the autonomy of women with mental illness is frankly just so appalling that I don't know how to respond to it. Women with mental illness deserve access to a dignified life. Thank you.
Thank you. I'd like to thank the witnesses for appearing. I'd like to briefly make mention several people referred to the Wilson judgment in Morgentaler as being relevant. I think it's a very good judgment, and I urge anybody who's interested in this to actually read that judgment. Let me point out that next week, Monday, Tuesday, we have meetings on both of those days. And if there's nothing else, I adjourn the meeting.
Thank you.